Hello. Can I please request everyone to take their seat? Those who are standing, please take your seat. We are going to begin shortly. એવું જ કરી દેવાય. હા, ચાલો હું કરી દઉં છું. કીધું તો છે. Hello. Good morning, everyone. Good morning and welcome to the Avron Physiocon 2023. First of all, I'd like to thank you all for being part of this wonderful event on this beautiful Sunday morning. And before we begin, can I please request everyone to put their mobile on a silent mode, please? Thank you. Thank you so much. Earlier, we had organized this Physiocon in 2019, and we had a wonderful response, and we had received some great feedbacks. But because of COVID, it took us some time to come up with another Physiocon. So here we are, and again, thank you all for coming. It is an honor to stand before you today as we gather to enrich our medical knowledge, exchange valuable insights, and foster professional growth. For today's event, we are fortunate to have an exceptional lineup of experts who will enlighten us with their expertise and shed us light on very interesting topics of their respective fields. Their knowledge and expertise will broaden our horizons, and it will empower us to deliver improved patient outcomes. So without further ado, let us commence this journey together with a prayer. Thank you. Now, I would like you all to introduce you to the Avron multi-speciality hospitals. Avron is a 65-bedded multi-speciality hospital and it's located in the heart of the city, and it's quite nearby. The address is over there only. It's in the Sardar Patel colony, Ahmedabad, India, and it's quite nearby from Vijay Char Rasta. You can approach from CG Road as well, from Stadium Crossroads as well. You won't miss it, guys. So Avron, as you can see, the building is right over there. It's an 8-floor building, and we have got our own pathology, radiology. We also got economic ward, twin sharing ward, single room, deluxe room, suite room, ICU, and of course, operation theaters. At Avron, we have got more than 20 specialties available, along with 2D echo, spirometry, treadmill testing, ultrasound, X-ray, our own laboratory, pharmacy, and dietitians and physiotherapy services as well. Avron Hospital is equipped with some of the modern equipments. Our operation theaters are all modular ones, and we also got advanced laparoscopic system, neuromicroscope, harmonic scalpel, battery-operated orthopedic drill, advanced OT light, hydraulic OT tables, 24/7 emergency care, and we also got in our economic ward, there is a TV for each and every patient, which is rarely seen in our city today. At Avron, we are commitment to the quality care. It is an NABH certified hospital, and we have recently received NABH for our nursing services as well. And I'm glad to inform you all that Avron is first hospital in the mid-size hospital categories to receive this prestigious certification from NABH, and we are also awarded Kaya Kalp from the Government of India. So as you can see on the screen, we have got some distinguished speakers which will cover various topics in their respective fields. Thank you so much. Now I'd like to request Dr. Piyush Patankar sir to come up and welcome all our guests and our speakers. He is a senior physiotherapist with more than 18 years of experience. He's also the conveyor of IAP Ahmedabad. Please welcome, sir.
Good morning. Yes. Still in Sunday mood, but it's fine. Physiotherapist ne Sunday પણ બહુ જ એનર્જેટિક હોવું જોઈએ. That what we all feel. I heartily welcome speakers and Avron Hospital, Alpa Madam and staff, and my physio friend. It's my privilege to announce Avron Physiocon and curtain raising this event. As a physiotherapist, we know that the today physiotherapist field is established field and recommended by all medical faculties. And 80s and 90s it was not. It was a struggling field. But due to hard work of our physiotherapist, we reached to the goal and appreciated by all medical fraternities. And that's not the end. We need to go further. Today, I am here and I'm sharing my few experience. I started my practicing in 1999 as a physiotherapist, and it was very tough time for me to establish as a physiotherapist. It hard works, it pays. At the end, I feel that I am the one who are making a big difference on patient's recovery. And certain point of my career, I realize that I am the one that I don't need anyone to help, and I am the extreme powerful person to get a recovery of all patients. And then somehow, two doctors are making a big difference in my whole perspective, and they are sitting just in front of me. My mother was suffering from a knee pain, right knee pain, and she was coming to my clinic daily and taking a treatment for the regular period, but she was not satisfied and not getting desired result for his knee pain. So one of my doctor friend recommended me to consult one super specialist, and to crushing my ego, I went to her, and he examined it properly and take a synovial biopsy, synovial fluid aspirations, and send it for investigations. And the diagnosis come as rheumatoid arthritis. And to my surprise, I'm just stuck that my mother is suffering from rheumatoid arthritis, and the diagnosis was done. And he was the one, he's just sitting in front of me, Dr. Deepak Dave sir. You diagnosed my mother as rheumatoid arthritis, and he recommended my mother to Dr. Sapan Pandya sir, and rheumatoid treatment started, and today she is fit and fine. She is doing yoga and everything, all the exercises, and she is completely normal. Because of these two superheroes, my mother are extremely happy and living his life. So, that point I realized that this two doctor taught me a lesson that without team and without proper guidance of super speciality, we can't focus on complete recovery of the patients. And that the point I changed my whole perspective of treatment. And today, we always work in the team. We always consider as a senior super specialist. I always tell them that they are the superheroes. They are Marvel superheroes. જ્યારે તકલીફ પડે ત્યારે જ આવે. And I am so happy that today we are here to get maximum learning from this all speakers. It is very difficult to help physiotherapy level to get extended in recovery pattern, but with this team we can make a big difference. When I started my practice, I learned lot of things from this super specialist, and I hardly get a time to get direct exposure or a question answering to get a maximum knowledge from them. But today you are here to get all these things on the single day and single shot. So guys, please don't miss this opportunity to get maximum extract from this to all speakers and all other speakers. So I hand over the mic to them, and I'm considering that this CME will be superb. Thank you. Thank you, sir.
Thank you, Dr. Piyush sir. Thank you for that wonderful speech. I'm sure we are all inspired now and looking forward to. So our first speaker today is Dr. Deepak Dave sir. He is one of the pioneers of joint replacement surgeries in Gujarat, and he is a leading authority in the field of orthopedics, and he is a wonderful speaker. I'm sure you all are going to have a wonderful time. And at the end of each session of our speakers, we have a short question and answer session. So if you have any queries, if you would like to ask any questions regarding their presentation or about anything, you can definitely ask them. And just in case, if we have missed your question, you can send us on our email address as well, and we'll definitely revert you back. Yep. And also, there is no language barrier. All speakers are comfortable with English, Hindi, Gujarati. So please be comfortable to ask questions in any language. Thank you so much.
So I think we have 5 minutes ahead. 9:55 is my time limit to start. And I have another 5 minutes. કેટલાને આમાંથી ગુજરાતી નથી આવડતું? નથી આવડતું? ઓહો 4-5 જણા છે. Okay, fine. So all these learned friends, Dennis, Sapan, spine surgeon, neurologist, Evergreen, Gopal, pulmonologist, Amit Bhai, neurologist, and ourselves, orthopedic. Our relations with you are either of ક્યાં તો મા દીકરીના અને પતિ પત્નીના, પણ સાસુ વહુના તો નથી જ. એટલે અમે તમારી પર સાસુગીરી કરીએ અને તમે વહુની જેમ અમને નુકસાન કરો એવું ના કરશો, બરાબર? લેટ અસ બિહેવ લાઈક આઈધર પતિ પત્ની અથવા તો મા દીકરી. આઈ થિંક દેટ ઇઝ અ ગુડ રિલેશન, બરાબર? એવું આપણે મગજમાં રાખીએ. Avron has finalized a solid team. We have evergreen solid Cheteshwar Pujara and one down, Dennis. Then we have Virat Kohli, Sapan Pandya. And then we have all-rounder Gopal, who is coming as Ravindra Jadeja. Amit Bhatt છે, અજિંક્ય રાણે જેવા, બરાબર? પ્રોબ્લેમ ખાલી મારો જ છે, કારણ કે મારે રોહિત શર્મા થવું કે શુભમન ગિલ થવું એ ખાલી ખબર નથી પડતી મને, કારણ કે ગઈકાલે બંનેમાં જ પ્રોબ્લેમ થયો. એટલે હું વિચારતો હતો કે સાલું શું બનવું, કારણ કે પછીની ટીમ તો સોલિડ જ છે આપણી પાસે. એનીવે, સો લેટ્સ સ્ટાર્ટ વિથ ધીસ એન્ડ એઝ ટોલ્ડ ટુ યુ, લેટ મેક્સ ધીસ ઇન્ટરેક્ટિવ. અમે તમને ભણાવવા નથી આવ્યા અને તમે અહીંયા ભણવા નથી આવ્યા. સો કીપ ઇટ લાઈક દેટ. અને I will try to make sure that we all finish in time. સૌથી અગત્યની વસ્તુ 1 થી 1.5નું લંચ છે આ બધામાં. હા, એટલે એ બહુ સારું જરૂરી વસ્તુ એ છે, એમાં મોડું ના થાય એમ. હા, એટલે એ આપણે ધ્યાનમાં રાખીએ. થોડું ઘણું એઝ વી સેડ, વી આર હેન્ડ ટુ હેન્ડ each other, right? Every day સવારે વી ગેટ અ ફોન કોલ ફ્રોમ યોર કલીગ્સ. ડેનિસને પણ એવા જ ફોન કોલ આવે કે સાહેબ શું કરવાનું છે, ઊભા કરવાના છે, ચલાવવાના છે, આ કરવાનું છે, ની બેન્ડિંગ કેટલું, ફલાણું ઢીકણું. સો વી ઓલ નીડ ટુ નો સમથિંગ newer. You also have lot of things in your specialty coming as up newer things, and we all have newer things. This is a medical science evolution, બરાબર? બળદગાડામાં ફરતા માણસો અત્યારે ફરારીમાં આવી ગયા. So innovation is a part of life, right? For everybody, every specialty, whatever it is, we need to do that. And the joint replacement surgery is one of the most innovative surgeries, like other surgeries, like endoscopic surgeries, transplant, bypass surgeries. So many wonderful innovations have come in the medical science, which has revolutionized the lifestyle, healthcare, completely changed. So the joint replacement surgery is one of them. And what is the aim is the pain-free movements, correct the deformity, and regaining the function. ત્રણેય વસ્તુઓ અગત્યની છે. You should have a pain-free, good, predictable results of daily activity. That is what we feel. Joint replacement માં શું evaluation થઈ શકે? What can be possibilities? તો in approach, બહુ જ લાંબા કટ મૂકતા હતા, right? We were putting big incisions, now it is a small incision, right? Design. So like a car, right? Every car, new car comes with a newer designs. They have a big computer and they have these facilities and this function and that function. So the design in the joint itself, the physics part is also equally important. Material, right? It's equally important, the material. જે ઓક્ઝિનિયમ, gold knee, તમે સાંભળો છો, you must be hearing about the gold knee, ceramics. So newer material has come. The plastic jointની અંદર there is one part is polyethylene, બરાબર? તો જેની પર મૂવમેન્ટ્સ થતી હોય એમાં બી વિટામિન E પોલી, હાઈલી ક્રોસલિંક પોલી, નવી વસ્તુઓ એટલા માટે આવે છે. મેથડ્સ, અત્યાર સુધી બધા જ ની રિપ્લેસમેન્ટ ગમે એટલો વારસ ની હોય પેશન્ટનો, the patient comes with like this, completely significant varus like this, but our instruments and jigs put it in 5 degree valgus. એટલે એક પગ ટૂંકો હોય, એક પગ લાંબો થઈ જાય, બંને વારસ હોય, અને બંને વારસમાંથી જ્યારે તમે એકને સીધો કરો તો it becomes straight and longer. So these legs, one become like that if you only operate one side. So people thought that the person who has been having a varus from birth, why to put them in valgus? So that mechanical alignment, જે આપણે ફિમરલ હેડથી ની અને નીથી એન્કલની જે લાઈન દોરતા હોઈએ, બધી ખાલી દોરીએ જ છે, કોઈ જોતું નથી, પણ એને આપણે વારસમાં જ થોડું રાખીએ, 2 ડિગ્રી વારસમાં જ રાખીએ. વાય ટુ કરેક્ટ સો મચ? સો કિનેમેટિક એલાઇનમેન્ટ. સો નવા પ્રિન્સિપલ, પીપલ સ્ટાર્ટેડ થિંકિંગ કે ભાઈ આટલું બધું શું કામ વારસમાંથી વાલ્ગસ કરી નાખવું, પણ 2 ડિગ્રી વારસમાં જ રાખો ને ભાઈ ચાલશે, આટલી આખી જિંદગી આમ જ રહ્યો છે. સો મિકેનિકલ એલાઇનમાંથી કાઇનામેટિક એલાઇનમેન્ટ આવ્યું. પછી યુનિ કમ્પાર્ટમેન્ટ રિપ્લેસમેન્ટ, વી ઓલ નો માઇક્રોપ્લાસ્ટી જેને શબ્દ વાપરે છે માર્કેટિંગ તરીકે, બટ બેઝિકલી ઇટ્સ એ યુનિ કમ્પાર્ટમેન્ટલ હાફ રિપ્લેસમેન્ટ. ક્યાં તો મીડિયલ ભાગ કરો, ક્યાં તો લેટરલ ભાગ કરો, કેટલાક લોકો એકલો પટોલોફ્યુમરલ કરે. હવે યુ ઓલ નો કોન્ડ્રોમલેશિયા પટેલી, પટોલોફ્યુમરલ આર્થરાઇટિસ, પેશન્ટના સ્પેસિફિક સિમ્ટમ્સ, પલાઠીમાં ઉભરક પગે ઇન્ડિયન ટોયલેટ પૂજા નમાઝ ગાડીમાંથી બહાર નીકળો ખુરશીમાંથી ઊભા થાવ. આમ રાત્રે બી આવું જ બોલાય છે એટલે આટલું ઝડપથી બોલું છું. સૂતી વખતે બી આવું જ બોલતો જાઉં છું. એટલે પટેલોફિમોરલ સિમ્ટમ્સ ઇઝ વેરી કોમન ઇન યંગ પીપલ. કોન્ડ્રોમલેશિયા પટેલી, એક્સક્લુઝિવ પટેલા ફ્રેક્ચર થયું હોય અને પટેલોફિમોરલ આર્થરાઇટિસ થયું હોય, મોટા મોટા પટેલામાં ઓસ્ટિયોફાઇટ્સ હોય, ચાલવા ઊભા રહેવામાં કોઈ તકલીફ ના હોય, બટ દે હેવ સ્પેસિફિક સિમ્ટમ્સ ઓનલી રિલેટેડ ટુ પટેલોફિમોરલ, રેસ્ટ ઓફ જોઇન્ટ ઇઝ ફાઇન, રાઇટ. અને સિગ્નિફિકન્ટ પ્રોબ્લેમ, વી કેન એક દાદરો ના ચડી શકે, ગાડી ચલાવવામાં, નીચે બેસીને ઊભા થવામાં, there are lots of problem. So there is patellofemoral arthritis also there, and for that patellofemoral replacement is also being done. Only patellofemoral replacement. So આવા નવા evaluation was going on. Robotic joint replacements, as you know, like you have a robot also in your physiotherapy armamentarium, navigation, and the important thing is evolution in the post-op recovery. એટલે pain management, એ બધામાં પણ there are lots of new things coming up. So the replaced joints, as we all know, the commonest are hip and knee, but elbow, shoulder, હવે એન્કલમાં પણ રિપ્લેસમેન્ટ્સ થવા માંડ્યા છે. સો બટ હિપ, ની, એલ્બો, શોલ્ડર, સ્મોલ જોઇન્ટ્સ, રાઇટ, રૂમેટોઇડની અંદર ધી MCP, IP joints replacements are also being done. Disc replacement, I'm sure Dennis is going to talk to you about that, so that is also replacement. And why the new innovations come? Only for 2 points. Everybody demands normalization. બરાબર, યંગ લોકો છે, 35 વર્ષનો માણસ, એ વાસ્ક્યુલર નેક્રોસિસ, એનું હિપ રિપ્લેસમેન્ટ કરો, એનો પહેલો જ પ્રશ્ન છે કે કેટલા વર્ષ ચાલશે, હાઉ મેની યર્સ ધીસ વિલ લોંગ. સો વી નીડ સમથિંગ વિચ કેન લાસ્ટ લોંગર. વી ડોન્ટ વોન્ટ અ સર્જરી. આપણે પેશન્ટને વોટ વી એક્સપ્લેઇન, લોંગ ટર્મ સેટિસ્ફેક્ટરી પ્રેડિક્ટેબલ પેઇન ફ્રી મૂવમેન્ટ્સ. અને પછી ફરી વાર કહું કે આ બધા શબ્દો અગત્યના છે. લાંબા ગાળાનું સંતોષકારક ધારણા પ્રમાણેનું પરિણામ આપે એવું સર્જરી, રાઈટ. So this is what we want, long-term satisfactory, predictable solutions which gives you all activities of daily living pain-free. That's the aim. હવે એ લોકોને they want કે જિંદગીમાં એક જ વાર કરવું છે. એટલે હું ઘણાને કહું કે મારી ઉંમરે કરશો તો એક વાર કરવું પડશે, તમારી ઉંમરે 2 વાર કરવું પડશે. બીજી વાર થઈ શકે. If you do surgery at 35, you do it at 65 second time, then you will leave at 95. So you will have to do twice. But if you do it at my age, probably you will have to do it only one time. But people don't want that. People want કે મારી જિંદગી, મારો જોઈન્ટ આખી જિંદગી ચાલવો જોઈએ. અને they want everything. તમે એને એમ કહો ને કે તમે સાયકલ ચલાવી શકશો, સ્વિમિંગ કરી શકશો, ગાડી ચલાવી શકશો, ટ્રેક્ટર ચલાવી શકશો, દાદરા ચડી શકશો, ઊભા રહી શકશો, કામ કરી શકશો, મોર્નિંગ વોકમાં બધું જ કરી શકશો, પણ સાહેબ ઇન્ડિયન ટોયલેટ નહીં વપરાય ને. અરે અત્યારે બી તું બેસતો નથી ભાઈ. પણ people don't want what is not achieved. So that's the thing. People think કે ભાઈ ના બધું જ થવું જોઈએ. So that is the reason why we want this evaluation. As I know, the traditional knee arthroplasty we all were knowing started way back 1980. પહેલાંથી ચાલુ થયું, મોટા લાંબા ઇન્સિશન મૂકતા હતા, એમાંથી મિની ઇન્સિશન્સ આવ્યા. મિડ વાસ્ટસ એપ્રોચ, સો quadricepsને બદલે we cut little, the tendon is spared. Then subvastus, we just go below the vastus. So whole of the quadricep mechanism is intact, and expect the patient to lift the do SLR same day evening. That's what we want to do. So we want to spare rather than cutting the quadricep tendon and doing the medial arthrotomy. આપણે આવું બધું કરીએ. ઇન્સ્ટ્રુમેન્ટેશનમાં there are lots of innovations which has come. Smaller incisions like this, which we all know, many people have been doing. You can see the size of this, which is pretty small. And when there is a small muscle cut and soft tissue dissection, your recovery is also going to be better and faster. So you can see that this is the staples જેટલા દેખાય છે, that's the size of the incision, which is pretty small, right? You can, the joint મોટો છે એના કરતાં એવું દેખાય છે, પણ this is what we can achieve. અને this is the less invasive, faster recovery. પાછું તકલીફ શું છે, કોઈ ટેકનિક છે નહીં, believe me. ઝીરો ટેકનિક, કે ટેકનિક, એમ ટેકનિક, દીપક દવે ટેકનિક, એવરોન ટેકનિક, ડેનિસ ટેકનિક, સપન પંડ્યા ટેકનિક, કોઈ ટેકનિક છે જ નહીં ભાઈ. The surgery is only done by one standard way. There is no single technique available. Approach can be different. You can doing a mid-vastus, you can do sub-vastus. But somebody claims that I have a technique of knee replacement. It is completely humbug and bogus, right? Similar to some people from your side claim કે ભાઈ અમે બધું જ મટાડી દઈએ, કોઈ ઓપરેશન અમારી તો જરૂર જ નથી આગળ. એટલે let's not go into those details, but basically it's a standard technique of knee replacement. It's absolutely, there is, with authenticity, I can tell you there is no other technique in the surgery. Navigation is not a technique. Robot is not a technique. We are talking about જે બધું લોકો બોલે છે ABCD ટેકનિક 0 1 2 3 4 ટેકનિક K ટેકનિક Y ટેકનિક M ટેકનિક ની ટેકનિક બધું એ બધું this is all words. એટલે મને એવું થયું હતું કે હું Z ટેકનિક નામ આપું, પણ પછી મેં વાંચ્યું તો કોકે કીધું છે Z ટેકનિક મારી પાસે છે એમ, એટલે મેં કોઈ જવા દો યાર હવે પછી હા D લખું તો પાછા કહેતા કે ડોબા ટેકનિક થઈ ગયા, એના કરતાં આવું નથી કહેવું આપણે. So design evaluation, as I said, right, lots of design. Again, ultimate aim is people want full flexion, full movements, બધું જ કરવું છે. સો તમારો ફ્લેક્શનની અંદર ની જોઈન્ટમાં સારામાં સારો લોડ the implant can bear, that is what we want, that is the design changes, right. એમાં પોલીએથિલિન બદલ્યું, એને સ્ટ્રોંગ બનાવ્યું, વિટામિન E પોલી કર્યું, વોટ એવર દે ડુ, પણ લોટ્સ ઓફ ડિઝાઇન્સ ચેન્જીસ હેવ કમ. રાઇટ એન્ડ લેફ્ટ, પેલું મારા જેવાનું તો પેલું 44 બી રેગ્યુલર તો ચાલે જ નહીં, એટલે આપણે પેલું 44 સ્મોલ પહેરવા જઈએ તો ટાઈટ પડે, એટલે આપણે 44 રેગ્યુલર જોઈએ. ડેનિસભાઈ હંમેશા રેગ્યુલર જ પહેરે, કારણ કે ફિટ એન્ડ હેલ્ધી માણસ છે, મારા જેવું પેટ છે નહીં એને. એટલે નીમાં પણ એવું થાય, ફિમેલ અને મેલમાં વી નો કે ભાઈ ઇન્ડિયન ફિમેલ્સ આર લિટલ શોર્ટર એન્ડ સ્મોલર, રાઇટ, આફ્રિકન્સ આર બિગ એન્ડ પંજાબી જેવા હોય, તો હવે નીમાં પણ સ્મોલ એન્ડ નેરો ડિઝાઇન્સ આવી ગઈ, સાઇઝીસ ઓન ટેબલ યુ કેન ડિસાઇડ. ટ્રાયલ રૂમમાં જઈએ ને આપણે એમ લાગે કે રેગ્યુલર જરા પહોળું છે અને પછી સ્મોલ જરા ટાઈટ પડે છે, તો ત્યાં ઓન ટેબલ ઓલ્સો યુ કેન ડિસાઇડ. સો ધીસ સોર્ટ ઓફ ઇનોવેશન્સ હેવ કમ. બેઝિકલી વી ટ્રાય ટુ મેચ ધ એનાટોમી, કે જેટલું બને એટલું પ્રયત્ન કરીએ. રાઇટ એન્ડ લેફ્ટ તો છે જ, બિકોઝ યુ ઓલ નો કે એનાટોમી ઓફ રાઇટ એન્ડ લેફ્ટ ફીમર આર ડિફરન્ટ, ટીબિયાની બી ડિફરન્ટ છે. રાઇટ એન્ડ લેફ્ટ ટીબિયા પણ જુદા આવવા માંડ્યા. ઓકે, સો ધોઝ સોર્ટ ઓફ થિંગ્સ came, high flex designs have come in, and we all know that people want to do gardening, this kneeling, cycling, sitting cross leg, બધાને બધું જ કરવું હોય છે. So we need to have the designs like this. લાંબુ ચાલે. So oxinium is one material which has come, and જેનું surface is very specific, અને એમાં wear resistance વધારે હોય, અને it avoids the risk of brittle fracture. This is one material. Normally cobalt chrome કે ટાઇટેનિયમ વાપરતા હોઈએ, એમાં ઓક્ઝિનિયમ આવે, કોટિંગ છે. એવી જ રીતે આ બાયોનિક ગોલ્ડ આવે છે, ટાઇટેનિયમ નિયોબિયમ નાઇટ્રાઇડ, જેને સાદી ભાષામાં ગોલ્ડ નહીં કહેવાય. ઇટ્સ અ કોટિંગ on the main design, but coating prevents the wear resistance, increase the wear resistance, and the longevity of this is increased. Allergy prevention, કેટલા બધા લોકો બુટ્ટી પહેરે, બંગડી પહેરે, ઘડિયાળ પહેરે, તો નિકલ કોબાલ્ટ ક્રોમની એલર્જી ઘણા લોકોને હોય. એવી જો પહેલેથી ખબર હોય તમને, if you know that you are allergic to these metals by wearing this chains and buttis and other things, then probably you can tell, and they can use this material which is the less allergic. Vitamin E poly, as I said, unicondylar, we all know, only half compartment. Medial is common, કારણ કે આપણે ત્યાં medial compartmental OA is common, but lateral પણ થઈ શકે, અને પટલોફીમોરલ પણ એકલું રિપ્લેસ કરી શકાય. કેટલાક લોકો પાછા એકલો મીડિયલ કરે ને એકલો લેટરલે કરે, આવા બધા જાત જાતના ખેલ લોકો કરતા હોય છે. પણ બેઝિકલી મીડિયલ OA ની માટે યંગ પેશન્ટમાં when knee replacement, full replacement is not required, right? This is a medial compartmental OA mate. This is an excellent surgery with a very fast recovery, small incision, almost full movements. So unicompartmental knee replacements, medial OA mate, half microplastico, ke half TKR ko, ke uni TKR ko, whatever word you use, this is a patellofemoral, only trochlea of the femur. ત્યાં પટેલાનું આર્ટિક્યુલેશન થાય ગ્રુવમાં, એ અને સામેનો ભાગ એટલો જ રિપ્લેસ કરતા હોય. So this sort of things have come. Navigation is there in the market since many years, and extension to that is the robotic surgery. So navigation has got lot of role in lot of specific indications. Mostly hip joint માં uncemented hip વાપરીએ, knee માં cemented knee વાપરીએ, પણ uncemented knee પણ આવેલા છે માર્કેટમાં. અને robotic arm, as we know, is also very useful for the precision. Fortunately, the instrumentation so far we have, and the long-term results which we have achieved so far, correctly doing, the use of robot is very minimally going to increase the precision part. The instrumentation are so precise કે અત્યારે બી આપણે we achieve a long-term satisfactory results without navigation and robot, but they are in the market and it's in this stage of evolution. Not the only problem with the robot is જે કંપનીનો રોબોટ લો એનો જ તમારે જોઈન્ટ વાપરવો પડે. So that's the main limitations we have. If I use X robot, I have to use that only. If I want to use Johnson implant, I cannot use. If I take a Johnson robot, I cannot use other implant. So that's the limitations with the cost. So that is what we have to see. Similarly, in the hip surgery also, the new thing which has come apart from the MIS is DAA, direct entry approach. Normally આપણે posterior approach કે lateral approach કરતા હોય. Now there is a direct anterior approach, hip માટેનું. It's a good approach, less invasive, and people claim and demonstrate, and there are results available કે almost all range of movements જે હિપમાં નથી થતી. The main problem with the hip is the range of movements which we get in the knee is not there in the hip. We all know કે squatting, sitting cross leg, પલાઠી, ઉભડક પગે, DAમાં તમે આ બધું જ કરી શકો એવું છે. આવા શોર્ટ સ્ટેમ્સવાળા જોઈન્ટ્સ પણ આવવા માંડ્યા છે. Surface replacement, which is not much in the market at the moment, but at one time this was giving full sports activity allowed with this. Gradually it has been withdrawn from the market for various reasons. The hot point at the moment is the ceramic. Any young people, right, the ceramic head or ceramic or ceramic and poly, that is giving you the longevity, right? And Biolux Delta, ceramic may be બે પ્રકારના. પહેલા હું yellow ceramic હતું, હવે આ pink ceramic આવ્યું, Biolux Delta. So the wear quality, એ બધું બહુ જ સારું છે અને you get a good range of movement. અને longevity is the main thing what we are looking at. Dual mobility. Dual mobility is also another beautiful design evolution, and it gives you almost good range of movements. હિપમાં એવું હોય કે 22.2.5 લો ફ્રિક્શન આર્થોપ્લાસ્ટી ચાંદલીએ જ્યારે ચાલુ કર્યું તો હેડની સાઇઝ 22.5 હતી. અત્યારે કોમનેસ્ટ ઇઝ 32 અને 36 ધ હેડ સાઇઝ. એઝ યુ ઇન્ક્રીઝ ધ હેડ સાઇઝ તમારી રેન્જ ઓફ મુવમેન્ટ્સ વધે. હવે તમે છો જ નાના, તમારો જોઈન્ટ જ 44નો કે 46નો છે, તો એમાં યુ કેનોટ પુટ 32 હેડ, રાઈટ? યુ હેવ લિમિટેશન્સ. 28-22 આવે. So dual mobility in a smaller size also gives you a larger cup size, head size, અને તમને range of movements વધારે આવે. ડિસ્લોકેશન્સના રેટ બહુ ઓછા, જે આપણા બધાનો પ્રોબ્લેમ છે, બરાબર? સો પ્રાઇમરી હિપ રિપ્લેસમેન્ટ્સ, એલ્ડરલી પેશન્ટ્સ, ડિમેન્શિયા હોય, ન્યુરોલોજિકલ પ્રોબ્લેમ્સ હોય, રિકરન્ટ ડિસ્લોકેશન થયું હોય, સોફ્ટ ટિશ્યુ પ્રોબ્લેમ્સ હોય, those are the patients who are at risk. This dual mobility is excellent thing. Unfortunately, dual mobility people are selling in younger age group to attract them કે તું પલાઠી વાળી શકીશ. That is not the indication so far. The designers themselves are not designed for that. પલાઠી વાળવા માટે આ જોઈન્ટ બનાવ્યો નથી. એની એડિશનલ ક્વોલિટી છે કે તમને સ્ટેબિલિટી આપે છે. બટ પીપલ સેલ ઇટ, રાઈટ? કે ભાઈ ના ના તું ડ્યુઅલ મોબિલિટી વાપર, પલાઠી વળાશે તારા દિન. પીપલ લાઈક દેટ. But it is mainly for the limited indications, as I said. It's a beautiful thing. We all know સર્જરી કર્યા પછી લોકોની પલાઠી વાળતા હોય છે. આપણા ના કહેવા છતાંય they do the sitting cross leg and things like that. See, people do this sort of activities. Milking, ગાય દોવાનું કામ પણ એ લોકો કરતા હોય છે. અને the most important things, you achieve these results and functions post-operatively with help of you people, right? Right, next day morning you are the one going and seeing them, provided they are pain-free. So the surgeon, પહેલો જ પેશન્ટ આવીને પૂછે સાહેબ બહુ પેઇન તો નહીં થાય ને? અમે એવું સાંભળ્યું હતું કે સવિતાબેન તો કહેતા હતા કે બહુ જ પેઇન થાય 4 દિવસ, બરાબર? રમણીકભાઈ તો આવું કહેતા હતા કે કરાવશો જ નહીં હો, એટલું બધું પેઇન થાય છે. સો એવરીબડી ઇઝ કન્સર્ન, નોટ ઓનલી યુ, the surgeon and the anesthetist, and mainly the surgeon, because we want them pain-free post-operative period so that they can help you to do the better physiotherapy and a good working. So preemptive analgesia છે અને બહુ જ રોલ છે. પ્રીવિયસ ડે ઇવનિંગ સવારે 7:30 સર્જરી હોય તો આગલે દિવસે રાત્રે 11 વાગે સ્પેસિફિક મેડિસિન્સ, પ્રીગાબાલિન, ન્યુકોક્સિયા, પેરાસિટામોલ, ટ્રામાડોલ જે કંઈ આપતા હો તમે, પણ પ્રીએમ્પ્ટિવ એનાલ્જેસિયા હેઝ અ સિગ્નિફિકન્ટ રોલ. અમારા કેટલાક એનેસ્થેટિસ્ટ છે એ એન્ટી એન્ઝાઇટી આપે, they just want the patient to be relaxed, બરાબર? અને the atmosphere in the OT has also to be little relaxed, right? ડેનિસભાઈની જેમ ગીતો વગાડવાના, પણ કેટલાક લોકો ફેંકા ફેંકીને મારા મારીને બૂમાબૂમી કરતા હોય, એના કરતાં you should have a very good atmosphere. Epidural analgesia, you all know about that, and that is another important point, which is for the pain control. We keep it 48 to 72 hours. Here your role is very important, because when you come next day, our associate colleagues of yours team, તો એ લોકો આવીને પહેલાં જ જોઈ લે કે ભાઈ કંઈ પાવર લોસ નથી થયો ને, ફૂડ ડ્રોપ નથી થયો ને, પેશન્ટ SLR કરી શકે છે ને, પેઇન કંટ્રોલ તો છે પણ સાથે સાથે મોટર ઇફેક્ટ નથી આવી ગઈ ને. That is what we need to see in the epidural analgesia. But it's a wonderful drug. Local blocks, adductor canal block, femoral canal block. You will be surprised to know there are papers. Knee incision આ મૂકીએ આપણે અને પટેલાની ઉપર સુધી કટ જાય તો ત્યાંથી થોડેક જ દૂર છે એડક્ટર કેનાલ. એડક્ટર કેનાલ તો ત્યાંથી ઇન્સિશનમાંથી અલ્ટ્રાસોનોગ્રાફી ગાઇડેડ બ્લોક આપી દે પીપલ. સો દે હેવ ડન લોટ્સ ઓફ થિંગ્સ. બોનમાં ઇન્ટ્રાથિકલ ને ગિવ ઇન્જેક્શન્સ, રાઇટ, ફિમોરલ કેનાલ બ્લોક, બધાના એડવાન્ટેજ ડિસએડવાન્ટેજ છે. કારણ કે પાછું ક્વોડ્રિસેપ પાવર જતો રહે એવું પણ પાછું ના જોઈએ આપણે. બટ પેઇન રિલીફ ઇઝ ધ મોસ્ટ ઇમ્પોર્ટન્ટ થિંગ્સ. PCA, પેશન્ટ કંટ્રોલ એનાલ્જેસિયા, એટલે what do surgeons want? Because we want early mobilization, enhanced recovery, maintain the muscle power, right, and minimal complications. That is what we want. એટલે non-opioid drugs, દરેકે દરેક મેડિસિન્સના પ્રોબ્લેમ્સ છે. ડાયક્લોફેનાક, બ્રુફેન, નેપ્રોસિન, good drugs, but we don't use in elderly people because NSAIDs we try to avoid in elderly people. Tramadol, બીજું કિડનીના પેશન્ટોમાં we don't use NSAIDs. ટ્રામાડોલ આપો, ઇટ્સ અ સેફ ડ્રગ. કેટલા બધા લોકોના વોમિટિંગ ને નોશિયા થતા હોય. બીજું છે પહેલી કમ્પ્લેન વોમિટિંગની હોય, પેઇન તો બાજુમાં જતું રહ્યું, બરાબર. સાહેબ બહુ ઉલટી થાય, બહુ ઉલટી, એટલે કહેવું પડે કે ભાઈ આઈસ્ક્રીમ મંગાવો, એટલે પાછા પૂછે વેનીલા કે મેંગો. અરે ભાઈ, એટલે પોઈન્ટ ઇઝ કે we have to be very careful about the post-operative recovery part. It should be smooth so that the patients get good feeling, right? પણ દરેક ડ્રગ્સના પ્લસ માઇનસ છે. લાઈક NSAIDs we don't give for the renal output problems. અમારા કલીગ્સ છે જે તમારી ફિઝિયોથેરાપિસ્ટ અમારી સાથે કામ કરે છે, તો દે આર ટ્રેઇન ટુ સી કે ભાઈ પહેલું જ આઉટપુટ જોઈ લે, યુરિન આઉટપુટ કેવો છે, સાહેબ કોન્સન્ટ્રેટેડ યુરિન છે, બરાબર. સો વી નો કે ભાઈ ડાયનાપાર ના આપતા, એનો પાછો નકામો ક્રિએટિન વધી જશે. So these are the things we have to look into the post-operative period. But as I said, overall epidural analgesia is an extremely good thing for first 2 to 3 days. And by the time patient gets properly used to the things. And there are lots of different type of material they use. કેટલાક રોપેવેકિન વાપરે, બ્યુપેવેકિન વાપરે, સેન્સરકેઇન વાપરે, કોન્ટ્રામલ વાપરે. So there are different dose according to the choice of anesthetist and surgeon. Ranawat cocktail, this is a very important thing, which we give local infiltration. This is combination of 4 or 5 drugs written here, right? And એ બધાનું combine બનાવીને પેરીઆર્ટિક્યુલર ક્વોડ્રિસેપ્સમાં, બંને મીડિયલ લેટરલ કોલેટરલમાં, પોસ્ટિરિયર સાઇડમાં, ટેન્ડનમાં, પટેલામાં, સોફ્ટ ટિશ્યુમાં વી ગીવ 100 ml ની સિરિંજ, આ બધું મિક્સ કરીને કોકટેલ, અને વી ગીવ લોકલ ઇન્ફિલ્ટ્રેશન. So that's also got important role in the post-operative pain management. So it's not only one thing, as I said, or avoid oral or IV route. We have patches like buprenorphine patches, we have suppositories, so people don't take orally and બીજા કંઈ નોશિયાના પ્રોબ્લેમ ના થાય. So એવા પણ હોય. But basically it's a multimodal therapy, right? You give pre-operative preemptive anesthesia, તમે local infiltration કરો, તમે epidural આપો, તમે patch લગાડો, suppository મૂકો, જે કંઈ suitable antibiotics અરે IV analgesics હોય એ તમે આપો. But try to make sure that patient is comfortable so that proper physiotherapy is being done into that. That is the whole idea of the pain, post-operative pain management. અને ખાસું મોટું science છે, because multiple pathways we have to block for the pain. So the whole idea of this is basically trying to go through a different route and make sure that patient don't get pain, they get easy recovery, helps in physiotherapy, બરાબર. અને as we all know કે ભાઈ the idea of showing this last slide is basically the functions which people can achieve, like doing namaz. We don't recommend in day to day, double click around one by one. People are doing the cycling, right, after bilateral knee replacements, and this 110 kg person is also fond of swimming. After doing the bilateral knee replacement with sheer determination, he is able to do this sort of activities. So the results like this people expect, they are possible, not by us alone, with help of you. Okay, so that is what we have to see. We should aim for the quality of life that is normal for the age and culture. બહુ જ અગત્યનું છે. મેં તમને કીધું એ પ્રમાણે 75 વર્ષની વ્યક્તિ કોઈ દાડો સાયકલ ચલાવી નથી, સ્કૂટી ચલાવી નથી, ને પછી તમે સ્કૂટી નહીં ચલાવાય? અલા ભાઈ, તું તારી જિંદગીમાં કોઈ દાડો સ્કૂટી પર બેઠી નથી, બરાબર? અને સો વી શુડ ટ્રાય ટુ એમ. આઈ શોડ યુ લેડી who is milking cow. I showed, this is the first slide, which the last slide I showed you, is a Maulvi in a masjid. This was the first requirement કે સાહેબ હું મંદિરમાં ધર્મગુરુ, મસ્જિદમાં ધર્મગુરુ છું, નમાઝ પઢવી મારા માટે જરૂરી છે, પઢી શકવાનો તો જ સર્જરી કરાવું. So what we should try to aim is the quality of life that is normal for age and culture, right? So with this, I thanks the team of Avron organizers, Alpaban, Jigarbai and Piyush, and my colleagues. Thank you all very much for this Sunday morning here. I have tried to be probably before time, so 9:55 થી 20 મિનિટ હતી, એટલે આઈ થિંક બરાબર ઘડિયાળ જોવી જ પડે સાહેબ. મેં તમને જમવાનું યાદ કરાવ્યું છે યાર, એટલે ભૂલતા નહીં તમે. મારી પછીના લોકોને બી વોર્નિંગ જ આપી દઉં છું કે 5 મિનિટ મોડું ના કરતા, નહીં તો હું તો થાળી લઈ જ લેવાનો છું. So any questions if you have? We have 5 minutes to discuss, and then I can hand over the Cheteshwar Pujara to come and do the solid batting. Dennis, you can start your things if you want. Ready, sir? Okay. Yes, madam.
Sir, my first question is lifespan of unilateral TKR. Is it same? It is having same lifespan as being the bilateral TKR or not?
Yeah. I think it's a good question. It's અત્યાર સુધી એવું મનાતું હતું કે it's an in between surgery, પણ એવું નથી. There are many cases where, and then lifespan is as long as the normal TKR. You can expect good 15-20 years result without any problem in uni. But normal TKR બી 25 વર્ષ ચાલવાનું અને પછી સર્જરી કરવાની આવે. Uni compartment, the only problem is the lateral compartmental OA. I mean, you do for the medial, but the balancing is not proper. Then patients later on develop the patellofemoral and lateral compartment symptoms. You have to do that. So it's not the life of the uni itself. It's the progression of the disease in the other compartments which compel you to come for second surgery.
And sir, my another question is, right now certain orthopedics are not suggesting physiotherapy after
Only one
even
in the
TKR.
world.
So sir, what do you say about that?
I've already told you, let's not be sasu vau, right? Because today morning I have seen the advertisements in the newspaper which says કે વગર ઓપરેશન બધું અમે મટાડી દઈએ છીએ. તમારા જ કલીગની જાહેરાતો છે.
Okay, I was not knowing that.
અરે રોજ આવે છે બેન, પાટિયા લાગે છે બહાર યાર, કેમ આમ કરે તું? And I'm repeating, out of 5,000 orthopedic surgeons in Gujarat, there is only one surgeon who promoted that without physiotherapy. 5,000 માંથી એક જ, પણ 5,000 માંથી 500 physiotherapy જેવું કહે છે કે અમે ઓપરેશન કરી મટાડી દઈશું. Okay, so I think both things are wrong. Okay, and as I said પહેલા જ કે પતિ પત્ની તરીકે રહીએ, નહીં તો મા દીકરી તરીકે રહીએ.
Sure, sir.
We need each other. And not my specialty. Yes. Dennis cannot do without you. Amit Bhatt cannot do without you. Right? Sapan Pandya needs you. Right? Is every Gopal, a pulmonary, he needs the specialist people in your branch, those who only do that work. So your super specialty is also gone into that. You know better than me, but there are musculoskeletal, there are neuro specialists, there are chest specialists, there are ICU specialists, pediatric.
Yes, sir.
બરાબર, તો છે જ બધા. તો એટલે it's a specialty work for you also. So I think it's a synergistic work, right? As I said, next day morning, if I don't get phone call from forum, right, then probably મારે એને ફોન કર્યો, બેન ઉઠી તું? તો કે હા, એટલે કહેવું નથી પડતું, પણ what I'm trying to say that we need your help from day one. So it's a synergistic action. Without physiotherapy, there is not a single paper in the world, right? And this is a marketing gimmick, and I try to touch the nerve of the patients. It's a good point, good thought. Physiotherapy નહીં કરવી પડે, અને આપણે કે કરવી પડે તો આપણી પાસે જતું રહે પેશન્ટ.
Yes, sir. I have seen this. That's why I'm asking.
કંઈ પણ મારી પાસે જતું જ રહે છે બાપા, કંઈ વાંધો નથી. પછી પાછું આવે છે.
Yes, definitely, sir. આવે છે patients, definitely પાછા આવે છે
So
because
we
of
should not
suffering.
worry about that part. Okay, fine.
Thank you,
All
sir.
right, okay, thank you. Yes, madam.
સર યુઝ્યુઅલી મારા પેશન્ટ્સનો ક્વેશ્ચન હોય છે કે બંનેની સાથે રિપ્લેસમેન્ટ કરાવવું કે સિંગલ સિંગલ
Yeah,
કરાવવું.
a good question. Both has got advantage, disadvantage. There are almost fixed guidelines now, right? High BMI, patients age more than 70, compromised cardiac function, any one of the comorbidities like diabetes, hypertension, angioplasty, kidney, right? Then we don't advise them. And severe deformities, જેમાં તમારે ઓગમેન્ટ મૂકવા પડે, રોડ મૂકવા પડે, તો એવામાં we don't advise the bilateral purely because of the medical issues, right? એટલે I think there are very certain guidelines by every good surgeons now કે ભાઈ above age of 70 તમે આટલા પોઈન્ટ્સ હોય તો તમે bilateral. But the advantage of doing simultaneous in a younger age group is also tremendous. કારણ કે see, as you all know, the first few days experience may not be good because of pain. અને પછી અમે તો ઘણા બધા પેશન્ટોને કહીએ કે ભાઈ સોમવારે આજે એક કરશું ને શુક્રવારે બીજું કરશું. બધું સમજાવ્યું હોય કે તમને થોડું પેઇન થશે, ચિંતા ના કરતા, તમારો આઉટપુટ, તમારો બ્લડ લોસ, રિપોર્ટ બધું બરાબર હશે, ગુરુવારે એનેસ્થેટિસ્ટ હા પાડશે, ફિઝિશિયન હા પાડશે, તો જ આપણે શુક્રવારે બીજું કરશું. ચિંતા ના કરતા, બે સાથે કરશો તો પારાપરથી તમારા બંને પગ ખરાબ છે, તોય ગુરુવાર રાત્રે એમ જ કે ના સાહેબ કાલ તો બીજું નથી જ કરાવવું, આપણે ઘેર જ જવું છે. Because they don't come out of that physical trauma sometimes. એટલે bilateral simultaneousના in a younger fitter age group there are extreme advantage. Now the surgeries are done very faster. પહેલાં શું હતું 3-4 કલાક થતું હતું, બરાબર? હવે કલાકમાં સર્જરી પતી જાય, સો એનેસ્થેસિયા ટાઈમ ઇઝ લેસ, રાઈટ? ફિટ પેશન્ટ હોય તો રિકવરીમાં કંઈ જ પ્રોબ્લેમ થતો નથી. They all walk next day like a single unity care. But you have to be, the most important drawbacks are two for bilateral. One is medical comorbidities and BMI. એમાં ન કરવું જોઈએ. Okay, I think we leave at this stage. Once again, thank you everybody, and I shall certainly see you at the lunch time.
As I said before, if you still have got any questions which you want Deepak sir to answer, you can send us those questions on our email. You can find our email on our website, and we'll definitely revert back. Our next speaker is one of the finest and most distinguished spine surgeons we have, Dr. Danish Patel. He has performed innumerable spine surgeries of all kinds and is also an expert in minimal invasive spine surgery. Dr. Danish Patel, sir, please.
Thank you, sir, for a wonderful talk and energetic talk. Now, my talk is on lumbar spine history taking and red flags. So, whenever patient have a back pain, you are the first point of contact for them. So, usually they visit you first. So, you should know how to evaluate a patient with a back pain, and you also know the warning signs, I mean red flags in that. So, you can refer patient timely to the consultant. History taking itself is an art. But nowadays, scenario is like that. Sir, I have already diagnosed myself on the internet. I am here only for the second opinion. But remember, a doctor who cannot take a good history and a patient who cannot give a good one are in real danger of giving and receiving the bad treatment. So history taking is of utmost important. You should see the patient as a whole, not only back. Your observation, your examination should start once patient enter into your cabin. See, this patient is walking with a limp, but you can easily identify he is walking with an antalgic gait. And if you observe carefully, he has a hip antalgic gait. So gait is such an important observation. If someone asks me, you are allowed to perform only a single examination, then I would perform a gait test for that patient. You should be a listener. Let the patient finish his symptoms, his whole narrations. You should have a patience. A patience is not only a virtue, but it is a vital necessity. Once patient finishes his symptoms, his complaints, ask the leading questions as needed. Many a times you will reach 80% of your diagnosis from the history itself. As I told you, you should observe the patient as a whole, not only back. You should observe how patient is behaving, how he is walking, what are his facial expressions, what is his body language. So you will reach so many diagnoses from that perspective only. Like you can diagnose anxiety disorders, sometimes depressions, some somatization. You can easily identify from the behavior things only. There are some pathognomic phase as well, like Parkinson's phase. This is easily diagnosable once you see the patient, and accordingly you can guide your treatment lines. Now see this patient. Patient comes to the OPD. Sir, આ બધું જ પકડાઈ ગયું છે ને આ બધું દુખી રહ્યું છે. At the same time, another patient has come. સાહેબ સખત પેઇન છે, હા, બહુ જ દુખાવો થાય છે, રહેવાતો નથી એવો દુખાવો થાય છે. What is the difference between these two? The second one is known as a McNabb sign. In first one, patient is showing his body part which is paining, while in second one, patient wants to convey you that part is so much painful that I cannot touch that part also. But you and me know there are no back condition in which there is a superficial tenderness. So clearly the second one is exaggerating his symptoms. So he is suffering from the somatization. So this is a McNabb sign. A patient who are suffering from a significant emotional overlay will frequently point to the area of pain in the lower back with their thumbs. They never actually touch their body part. So this is a psychology you should know. So you can diagnose somatization in this way. Whenever patient is coming to you, they are narrating their symptoms, try to identify and try to classify their symptoms into three main boxes: a back pain box, a leg pain box, and sensory symptoms. We'll see each box one by one. First of all, back pain. Apart from some exceptions, most of the time, whenever patient is complaining of their back pain, they will fit into any one of these frame: mechanical pain, instability pain, discogenic pain, arthritic pain, and inflammatory pain. Let's see characteristics of each pain box one by one. Mechanical back pain is also known as a postural pain. That is due to weakness of the paraspinal muscles and fatigue. Usually they complain of a boring diffuse pain at the lower back and DL junctions. It would be mostly paraspinal in location. They won't have any pain in the morning. Once day pass, once their activity increase, they have a pain. Mostly they are people with a sedentary lifestyle, they are computer worker, or they have a sitting job. It relieved with the rest. It is completely in your territory. You know better than me how to treat this kind of patients. They need exercise as per your protocol. They may be benefited by core-strengthening exercise. Always teach them ergonomics so they can practice these trips and ticks at their working atmosphere, and they can have a maximum benefit of ergonomical muscle balance. Can you read this X-ray? Anyone? So it is a L4-5 lytic spondylolisthesis grade 2 associated with L5 lysis. So this is a instability in spine, and that can give rise to an instability pain. The pain increase with the position change. Whenever patient get up from the prolonged sitting position, they have a pain. Whenever they get up in the morning, when they first get up from the bed, from lying down position, they have a pain. So first activity after an prolonged inactivity will give rise to a pain. At rest, they won't have any pain. At continuous activity, they won't have any pain. So from this criteria, you can diagnose instability pain. Whenever you suspect this kind of symptoms, always ask for dynamic X-ray. What is dynamic X-ray? It is a lateral spinal X-ray in flexion and extension. So it can be helpful in unmasking the hidden instability. As you see in this example, in extension, everything is getting reduced, but in flexion, L4-5 instability, which is hidden, is unmasked. So this is important in diagnosing instability. At the same time, it has a therapeutic value also. As you know here, extension is reducing the patient's instability. So this patient can be benefited from the extension McKenzie protocol rather than flexion protocol. A lumbosacral belt also would be helpful in this kind of patient. Can you read this MRI? It is an very good. So it is a sagittal image of lumbar spine showing L4-5 disc degeneration with an annular tear. So nowadays MRIs are doing more frequently. So patients comes to the OPD. સાહેબ આમ તો મને કોઈ તકલીફ નથી, નાનું મોટું બેક પેઇન હતું, પણ મારા સાહેબે કીધું MRI કરાવી લો. તો મેં MRI કરાવ્યો અને એમાં એક તો ગાદી ખરાબ થઈ ગઈ છે, કાળી પડી ગઈ છે, પાણી ઘટી ગયું છે, ગાદી સુકાઈ ગઈ છે અને હવે કંઈક ગાદી બદલવાની વાત થઈ રહી છે. Believe me, it is a normal thing. Out of you 100 people, if I ask for an MRI, out of 100, 20 to 30% of normal individual will have this kind of picture. So this kind of picture is not always symptomatic. So try to differentiate symptomatic back pain from this kind of picture. So whenever this kind of disc degeneration is symptomatic, it is called asymptomatic disc degeneration. They have a more pain with the flexion posture. They have a more pain in morning. And whenever you load this patient axially, means if they lift some weight or if they sit for a prolonged time, they have a more pain. So this is a discogenic back pain. And criteria to treat this kind of patient is different. This is a MRI axial image of a normal individual. Patient is lying supine. So you can see here, this is a vertebral body. These are the facet joint. So these are the facet joint. This is a canal which is completely clear. So it is a normal MRI. But if you compare with these images, you can see here the facet joints are completely degenerated and they are facetal effusions. The cartilage is completely wavy. So these are arthritic facet and this can give rise to an arthritic pain. Obviously these individuals are elderly people. They have a much of morning pain. The extension will load their facet and they have a more pain in extension. With continuous activity they have a more pain. With rest they have their pain get relieved. So prefer isometric exercise for this kind of patients. Avoid movement if possible. Avoid extension at all because extension will load their facet and again they have a pain. A lumbosacral belt will help this kind of patient. They need some medical management as well because there is an inflammatory component and they need some anti-inflammatory medications. In few refractory patients, they need a facet block as well. Now can you read this one? It is much obvious. It is a bamboo spine. So we see this kind of picture with ankylosing patient and other spondyloarthropathy patients. These are the young patients and they have a morning pain. This is a spondyloarthropathy, inflammatory condition, and they can have a back pain, termed as a inflammatory back pain, which is very resistant to physio treatment. So don't give this patient manipulative treatments because it is already a bamboo spine. It is a solid spine. You cannot manipulate that spine. They will be benefited from some modalities, but exercise should be avoided in these patients. They are resistant to treat by physiotherapy and they are difficult to treat. They need some anti-inflammatory medications and most of the time they need a reference from someone by rheumatologist's opinion. Now that is a story for the back pain. Now coming to the leg pain. Whenever patient is complaining of leg symptoms, try to identify and try to categorize as whether it is a referred pain, whether it is a radicular pain, and whether it is a local pain. What is the difference between these all three? Let's see one by one. What do you mean by referred pain? A pain is producing somewhere else, pain generator is somewhere else, and pain is felt at somewhere else. Such as in sacroiliac case, sacroiliac joint pain, they may have a pain at sacroiliac joint, but sometimes the pain will radiate, refer to the buttocks, they sometimes refer to the posterior thigh. Same way in the facet joint, they may have a pain paraspinally, but many a time it can refer to the buttocks and it can go to the posterior thigh. In knee joint also, most of the time they have a pain around the knee, but sometimes there would be a reference pain of patellar things or synovial effusion, they have an anterior thigh pain. And if patient has a posterior horn meniscal injury, they may have a pain over the posterior thigh and posterior calf. So sometimes it exactly mimics the radicular pain, and sometimes picture is so confusing that we have to take an opinion of our orthopedic team. So whether it is a knee origin pain or whether it is a spine origin pain, and sometimes situation is so tight that we have to give a local anesthetic block either into the knee or either into the spine to differentiate this kind of patient. Radicular pain is relatively easy to diagnose when it is associated with the numbness because it follows the dermatomal distribution. So you can see here the first one is an L5 radicular pain, second one is L4, third one is S1, like L1, L2 and L3. Whenever patient has a below knee pain, mostly it is a radicular pain, except for the knee condition where meniscal injury is there and referred pain. Otherwise, mostly it is a radicular pain, because out of 100, 95% a patient have a problem at L4-5 or L5-S1, because they are most mobile segment of the spine and they degenerate early. So if you consider L4-5 and L5-S1 disc degeneration, then patient may have a radicular pain either of L4, either of L5 or either of S1. All three dermatomal distribution will go below knee. So whenever patient has a below knee pain, once you rule out knee referred pain, it will be a radicular pain. Now coming to the local pain. Sometimes a local pain can create a googly situation. Let's see by case discussion. This gentleman has a tibialis anterior weakness and L4 dermatomal pain, and he was referred for surgical intervention. MRI shows L4-5 left-sided disc prolapse. Here the clinical situation and radiological situation is not in line to line. They are not matching. If it is a L4-5 left-sided disc, it could have given a left L5 radicular pain, but here patient has a L4 dermatomal pain and L4 weakness, so it is not matching. The next thing is disc prolapse is such a small that this kind of disc prolapse cannot give a weakness, but here patient has a weakness. So there is no matching of clinical picture and radiological picture. So I examined this patient in detail. What I found is a cystic swelling at a proximal tibiofibular joint. And in imagination, it was a cystic lesion of proximal synovial tibiofibular joint. This patient was referred back to orthopedician. That symptoms was because of the peroneal nerve compression at the knee. They removed this cyst and patient was completely fine. Now coming to the second case, an elderly gentleman referred for a spine surgery. He was in wheelchair. He has an anterior thigh pain. He was not able to walk. That's why he was in wheelchair. At the first step only, he has a significant pain. So he was reluctant to walk at all. He was not able to put weight on his leg. At rest, he was comfortable. So here again, there is a clinical radiological mismatch. A patient, he is a L4-5 stenosis, as you see in this picture. He has a myeloblock as well. So if it is a L4-5 stenosis, patient should have a L5 radicular or S1 radicular, and it should be a below knee pain. But here patient has an anterior thigh pain, which is not matching. Second thing is, a patient has a pain at the first step only. You have seen many patients of lumbar stenosis. What they complain, once they walk for few steps, after that they have a pain. But here the pain is at the first step. So it should ring a alarm in your brain that this is not matching. So I examined that patient in detail and I found hip rotations are painful. So I asked for an MRI of hip and it was positive for the stress fracture. This patient was given a rest and he was completely fine. So this kind of local pain complex, sometimes they create a googly situation. Just like a greater trochanter bursitis. Patient may have a lateral side of thigh refer pain. You may believe it is a facet pain or you may believe it is a sacroiliac joint pain. But patient says, સાહેબ હું એ પડખે ફરીને સૂઈ શકતો નથી, ફરીને સૂઉં છું તો મને બહુ પેઇન થાય છે. હું પલાઠી વાળીને બેઠો હોઉં અને ઊભો થાઉં છું તો મને બહુ જ પેઇન થાય છે. અદરવાઇઝ હું ઇન્ડિયન ટોયલેટ માટે બેઠો હોઉં છું તો પેઇન થાય છે. હું એક પગે ઊભો રહીને કંઈક મારા ઇનર્સ પહેરતો હોઉં છું તો મને પેઇન થાય છે. ઇટ કુડ બી એ GT bursitis also. In the same way, peroneal tendinitis can mimic like a L5 radicular pain. But if you see the local part in detail, they have a swelling in the peroneal groove. The reversion is painful. There would be a local tenderness. And by this careful examination, you can differentiate this diagnosis. Now coming to the sensory symptoms. Whenever patient complains of tingling numbness, you just try to differentiate whether it is a dermatomal distribution, whether it is a non-dermatomal distribution, whether it is a continuous in nature or whether it is related to particular posture or movement. If it is dermatomal, if it is related with particular posture and movement, it is of root origin and it could be a spinal origin. But if it is a non-dermatomal, it is continuous in nature, mostly it is some neurological things. Refer to Amit Bhai for this kind of patients. You should ask diurnal variation also. Like in peripheral neuropathy, they have a more pain at night. They have a more burning at night, but daytime they are comfortable. You should rule out RLS also because they have a nighttime restless leg complaints. So these are the history part. Now we are going to discuss a red flags. What do you mean by red flags? So they are symptom complex which indicate some serious pathology is going inside. So they are important. Whenever you find one or two red flag in any patient, try to investigate that patient more and ask your consultant to see this kind of patient urgently. Night pain. Usually degenerative patient, once they be in sleep, they won't complain anything. They won't have any pain. But some pathology like intradural tumor, they have a pain at night. Patient says, સાહેબ હું સૂઈ તો જાઉં છું પણ રાતે 2 વાગે છે ને અચાનક પગ દુખવા માંડે છે ને હું ઉઠી જાઉં છું. What is the mechanism here? When there is tumor is very small, it won't give any symptoms in daytime. But whenever patient sleeps in supine position, because of gravity, that tumor settles down over the cord and patient has a leg complaints. So they will wake up at the night and they have a pain. They say કે સાહેબ પછી 5-10 મિનિટ બેસું પાછો સૂઈ જાઉં છું તો પાછી ઊંઘ આવી જાય છે. In the same way, any infection into the spine, because of the protective spasm mechanism, in daytime they won't have much pain, but in night time, because of the skeletal muscle relaxation, their protective spasm mechanism will be wear off and that hidden instability unmasked and they have a pain. So they just get up from the sleep. So this is important. Second thing, whenever patient is coming with imbalance, they have a dexterity loss, thinner, hypothinner muscle wasting, interosseous lumbrical muscle wasting. They have a writing difficulties, chopping difficulties, eating difficulties, buttoning, unbuttoning difficulties. These are the patient whom you can suspect cervical myelopathy and they clearly get benefit from early intervention. So refer immediately this kind of patient to your consultant for further checkup. Same way, continuous numbness. You see lumbar claudication patients, you are managing, patient says, સાહેબ હું ચાલું છું ને તો પગમાં ખાલી ચડી જાય છે પણ બેસું છું ને તો કમ્પ્લીટ મટી જાય છે. સાહેબ ઊભો રહું છું તો પગમાં ખાલી ચડી જાય છે પણ હું બેસું છું ને તો કમ્પ્લીટ મટી જાય છે. That means they have a claudications. You can manage them very well. But whenever this kind of patient complains, સાહેબ પહેલાં ચાલવાથી ખાલી ચડતી હતી, બેસવાથી મટી જતી હતી, પણ હવે તો બેસું છું ને તોય 24 કલાક ખાલી રહે છે, રાતે સૂતો હોઉં તોય 24 કલાક ખાલી રહે છે. That means it is a sign of nerve injury. It could be a progression towards the irreversible neurological damage. So this type of patient needs an intervention. So refer them to your consultant for further surgical treatment. And obviously bowel bladder symptoms. Whenever in the treatment of this kind of patient you find any bowel bladder symptoms like perineal numbness, like hesitancy, urgency in passing urine, incontinence, always ask your consultant to see this kind of patients. Obviously there are differential diagnoses of prostate and other things, but they should have a look of your consultant. In the same way, if patient develop neurodeficit during the treatment, you should refer them to consultant. Now, there are few patients who are very young, less than 20, and they are complaining of constant back pain. It is obvious that they patient won't have a degenerative condition in their back. It could be either infection or either congenital anomaly. So this kind of patient needs investigations. At the same time, your patients who are refractory to treatment, they are not improving, they are elderly, think of metastasis or some other tumor pathology in elderly patients. Whenever patient have a history of high velocity trauma, like road traffic accident, if they have a fracture like this, it looks like a benign fracture. Like this patient was treated by some big banner physiotherapy center. This patient was given a traction, sir. There's some manipulation exercise to check out that vertebral wedging and to open up the vertebral wedging, and that patient developed paraparesis. Then we have to operate this patient immediately. So never ever think any fracture as a benign fracture. Always investigate and ask your consultant to see this kind of patient. Actually, this patient has a 3-column injury. You can see in this CT scan the pedicle is broken. So it is a anterior, middle and posterior column completely shattered off, and this patient is highly unstable injury. At the same time, if any patient in your follow-up, they are not improving, they have constant pain and pain is getting worse, pain is non-mechanical in nature, always think of metastasis, always think of infection or some other serious abdominal or vascular pathology. Like in this patient, he was wandering here and there since 6 months with his back pain and bilateral groin pain. So I just investigate because it was not fitting in any of box, and I found a huge aortic aneurysm. So this kind of things can happen. Now we are talking of lumbar back pain, but whenever patient is complaining of thoracic pain, particularly with thoracic radicular pain. When they have a girdle pain, means rib cage radiating pain, never take it lightly, because thoracic spine is relatively a stable segment because of ribs and sternum. So degenerative conditions like disc prolapse, facial arthropathy won't sit in thoracic spine. If patient has a thoracic pain, think of other etiology like metastasis, infection, or some tumor-like pathologies. So investigate this kind of patient frequently. You should always ask a past medical history to the patient, like cancer, systemic steroids, HIV infections or other infections, any other constitutional symptoms like weight loss, anorexia, or fever, because they may have a paraneoplastic syndrome hidden, or they may have infections. So these are the red flags. Whenever you observe these kind of things, just investigate patients more and try to take an opinion of your consultant. Thank you. Aim of our spine society to increase the level of knowledge of physiotherapy colleague, so you can be a spine physician. We are surgeon. It is not our job for a routine spine things to see. I think government and all our society should do something to facilitate this kind of things, so you can be considered as a spine physician. Thank you.
Question.
Any questions?
ઇફ પેશન્ટને ટી સ્કોર બિલો ધી નોર્મલ લેવલ હોય અને ઓલરેડી સર્જને સર્જરી કરી દીધી હોય તો વોટ કેન અવર રોલ એન્ડ યોર રોલ?
હવે સર્જરી કરી દીધી છે એટલે અમારો રોલ તો બહુ છે નહીં એમાં. But whenever there is a disc prolapse and once you do the surgery, you have to cut the annulus to remove that fragment. The annulus is made of a collagen material, so it is hard to heal. So you have to give 3 to 4 months for that annulus to heal. So don't give any active physiotherapy for 3 to 4 months. Once annulus is healed and patient is symptom free, then you can give flexion isometric protocol for this kind of patients. This is not for the surgery itself, but this is to prevent other disc level degeneration also, right?
Okay, there are chances कि with medication there increase in calcium level and surgery is automatically like healed and something, because after 3-4 months patient is not relieved and so much pain in sitting, sideline sitting, everything.
If patient is not getting relieved, then maybe your diagnosis is wrong and things are wrongly done, maybe. So you have to evaluate this patient thoroughly again. There may be a pain generator somewhere else and surgery was done for the asymptomatic disc prolapse also. That's why history is important, that's why examination is important. So you can avoid your failures.
Okay, thank you so much,
Yeah.
sir.
Thank you. Any other questions? I will encourage questions because it would be a bilateral learning. Any other questions? Yes, madam.
Sir, PIVD and spinal stenosis both are different condition, but in most of cases we see that due to PIVD the spinal stenosis occurs, but it both can different diagnosis and different symptoms can given to how we could differentiate the both conditions.
PIVD and spinal stenosis, they can be in correlations. Like
Okay.
a patient has a central broad-based chronic disc, so it won't give inflammatory symptoms like we see in acute PID cases where the inflammation is more. Whenever disc prolapse happens, what will be the things inside? It is not only mechanical compression over the nerve root. Because of the disc prolapse, there is a inflammation, right? Like our lens material, which is never ever exposed to the immune system. So for immune system, it is very naive. The same way our disc material, disc is avascular. So whenever there is a disc prolapse, the disc material will come in contact with our immune system. And there is an intense immune reaction. So there is an intense inflammation there. So the patient has a severe pain. This can be considered clinically as a acute PID, right?
Yes.
But whenever there is a disc prolapse, which is broad base, which is chronic, So it would be a diffuse broad-based disc prolapse, and which will do a anterior compression and stenotic symptoms. So this kind of disc prolapse patient will behave like a stenotic patients, right? At the same way, when there is a stenosis because of the facet joints, and there is a facet synovial cyst, so it can cause an acute compression, and patient has a acute symptoms just like in disc, but actually it is a facet cyst. Actually it is a stenosis. So they can overlap each other. So you have to differentiate by radiological investigations. Okay?
Thank you, sir.
Any other question? Yes, sir.
Good morning.
Good morning, sir.
I read one paper regarding role of surgery and physiotherapy in lumbar canal stenosis, and they suggested that results are in both equivalent. I just wanted to know your opinion and what are the indication of surgery in lumbar canal stenosis?
What is the natural history of lumbar canal stenosis? Paper says out of 100, 33% of lumbar canal stenosis patient will improve, while 33% of patient of lumbar canal stenosis that will be stagnatory. They won't improve, they won't worsen. They are just managing their lifestyle, and 33% will worsen. In that 33% surgery is indicated. So decision of surgery is not by patient's only symptoms, not by radiology. It is a combined decision. That's why I told you have to see patient as a whole. I just explained two case scenario. One patient, both have a severe spinal canal stenosis. In fact, one patient has more stenosis. One patient is coming to the OPD. સાહેબ હું કિલોમીટર ચાલું છું ને તો મને પગમાં ખાલી ચડી જાય છે, અને 15 મિનિટ ઊભો રહું છું ને તો મને પગમાં ખાલી ચડી જાય છે. પેશન્ટ 76 વર્ષના દાદા છે. એટલે મેં એમને પૂછ્યું કે તમારી લાઈફસ્ટાઈલ શું છે? સાહેબ મારે તો ઘર ખાટલેથી ટેબલ ઉપરથી ખાટલે, એના સિવાય મારે કશું કંઈ કરવાનું થતું હોતું નથી. આ તો ક્યારેક કોઈ ફંક્શનમાં 6 મહિને એકાદી વાર ગયો હોઉં, વધારે ઊભા રહેવાનું થાય, ચાલવાનું થાય તો જ મને પગમાં ખાલી ચડે છે. He has a severe spinal canal stenosis. He is not a candidate for surgery because his lifestyle is not demanding that much. At the same time, another guy has come with less severe stenosis radiologically, but he says, સાહેબ હું 1.5 કિલોમીટર ચાલું છું તો મને પગમાં ખાલી ચડી જાય છે, અને હું અડધી કલાક ઊભો રહું છું તો મને પગમાં ખાલી ચડે છે. He is a young patient. He wants to walk every day 5 kilometers, but because of these symptoms, he is not able to walk. He is a candidate for surgery. So it is not only a radiological thing, it is not only a clinical thing, it is a patient's demand also. And many a times whenever there is a stenosis, we always wait for 4 to 6 months to get it settled by natural history rather than physiotherapy or medications. By physiotherapy and medications, sometimes we are just buying the time from the nature. So we'll allow them to settle by its own. If it is not getting settled after 4 or 6 months, then we'll advise surgery. Yes, any other questions?
Sir,
Yes, sir.
excellent presentation.
Thank you.
And very good explain about the red flags. Usually the surgeons don't put so much effort in this type of clinical examination as physiotherapists do. I have just only a single question.
Okay.
That patient, how will you differentiate between vascular claudications and a neurological claudications clinically?
A very good question. Both have a same complaints. Symptom wise, they are not able to walk, they are not able to stand. But if you ask in detail, in vascular claudication, they have a more of burning and tightening pain rather than numbness. That is on patient symptomatology point of view. If you examine them, they have a absent distal pulsations, or they are feeble. You can see the other signs of wasting also. They may have a less hair on their shin. The shin skin is very thin because of the vascular, less vascularity. They have a black skin. And the other thing, if everything is going neck to neck and you are not able to justify by your clinical examination, by radiology or by patient symptoms, then 2 other tests are there that can be easily differentiate whether it is vascular or neurological. You ask patient to walk uphill, right, like this, and not step, but it's just slope. So if it is a vascular claudication, patient's demand of walking would be more because patient is going uphill. So their muscles have to work more. So patient would be get early fatigue. If patient is able to walk on the road for 1 kilometer, he would be have a fatigue at the 500 meters only. If patient has a neurological claudication, while walking uphill, he has to bend like this to walk uphill. So that bending will open up the spinal canal. So he would be able to walk more. So if patient's claudication time is 1 kilometer, with slope, a vascular patient have a 500 meter claudication, while a lumbar canal stenosis have a 1.5 kilometer claudication time. So in this way you can differentiate. Another thing is cycling. In cycling, patient's back is steady and it is in flexion posture, and patient is doing pedaling. So he is not actually walking. So vascular patient have a symptoms early because their calf muscles are working, their blood demand is there. While in lumbar canal stenosis patient, their back is fixed. He is not walking actually. So he won't have any pain. So by cycling test and slope walking test, you can differentiate this vascular or neurological claudication. Right.
Thank you, sir.
Any other questions? Because questions are creating more discussion and we can have more knowledge.
Good morning, sir.
Good morning, Ben.
Sir, can phleboliths create referred pain?
Sorry?
Phleboliths
Phlebolith create?
refer pain?
Usually
lower
not.
limb or
Usually not.
Okay. Because I have one patient who have phleboliths, but her referred pain or the radiating pain, it's not decreasing. And she's having SI joint dysfunction. So
Could be the other cause for his or her pain.
maybe, sir.
Right.
Thank
Thank
you,
you.
sir.
Thank you. Other question? No questions? Shall I finish? Okay. Thank you. Thank you.
Thank you very much, Dennis sir, for the wonderful session. Now we are going to have a lamp lighting ceremony, and for that I would like to invite all our distinguished speakers, Dr. Deepak Dave sir, Dr. Sapan Pandya sir, Dr. Gopal Raval sir, Dr. Amit Bhatt sir. Please come up on the stage. Piyush Patinkar sir, please. Chiga sir. We have our founders of Avron Hospital, Jagrut sir, Ketan sir, Parin sir, Manan sir, Alpa ma'am, Khyati ma'am, please come up on the stage.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुंड मा
Thank you so much, everyone. Thank you. Now we are going to have a small tea break of 10 minutes, right? We have got some exciting topics lined up after the tea break. So you guys can have a little bit of a break and please come back after 10 minutes. Thank you so much.
ફોલ્ડર બનાવીને લઈ
સર અમિત શર્મા તો આપણે સેવ કરી લીધું છે સેકન્ડ સેવ કરીને કરી દઈશું ને હા એમાં ફોલ્ડર કરી દઈશું પર ઓપન કરી નાખશે એટલે સરને બતાવી અમિત શર્મા તો છે અમિત શર્મા છે સર પેલું તમે આ તમે અલ્પા મેમને મોકલી તો એ જ છે ને સર કે બીજું છે આ પીડી લખેલું છે
ઓકે સર
આઈ થિંક લગભગ આવી ગયા છે હું કરી દઉં છું.
हेलो
Hello, may I have your attention, please? Now we are going to start our after tea session. Today's Physiocon is not confined within these walls. Actually, we are live on FB and Insta as well. We have more than 200 candidates attending this session as well. So I'd like to welcome you all as well. Our next speaker is Dr. Sapan Pandya sir. He is one of the most renowned rheumatologists of our country, and sir's expertise extends beyond his clinical practice, as he has actively conducted groundbreaking research and innovations in the field of rheumatology. Dr. Sapan Pandya sir.
મોર્નિંગ એવરીવન. થેન્ક યુ અલ્પાબેન, જાગૃતભાઈ, જીગરભાઈ, નીરવભાઈ, બધા મિત્રો, કેતનભાઈ, અમિત, દિનેશ, દીપકભાઈ. સાહેબ તો ગયા, પાછા આવશે કદાચ. મને હવાનો હાથ ઝાલીને રખડતા આવડી ગયું છે. મને ખુશ્બુની રગ પકડીને ફરતા આવડી ગયું છે. અને બધા ખમતી ધરો વચ્ચે મારી નોંધ લેવાશે, મને ભરી સભામાં સૌની નજરે ચડતા આવડી ગયું છે. ને હવે આનાથી નાજુક સ્પર્શ હોય બી ક્યાંથી મને પાણીના પરપોટાને અડતા આવડી ગયું છે. સો આઈ થિંક ધીસ ઇઝ આફ્ટર અ ડેકેડ દેટ આઈ એમ ટોકિંગ ટુ ફિઝિયોથેરાપિસ્ટ. આઈ ડોન્ટ નો, અલ્પાબેનને યાદ હશે વર્ષો પહેલાં. અને બિફોર આઈ ગો ઓન વિથ માય ટોક, આઈડ લાઈક ટુ ટેલ યુ અ સ્ટોરી. I was in one of these meetings at the Jaipur Literature Festival, which I regularly go almost every year for the last 2-3 years. Predominantly because my wife is a fan of Shashi Tharoor. And I go there, and ત્યાં એક અમેરિકન કાઢ્યો હતો, તો એણે કીધું કે ઇન્ડિયન્સ આર ફોન્ડ ઓફ નેરેટિવ્સ, સ્ટોરીઝ. તમે ઇન્ડિયન સાયન્ટિસ્ટને કે ડૉક્ટર્સને બહુ ફેક્ટ્સ ને સ્ટેટિસ્ટિક્સ આપો ને તમને મજા ના આવે. But if you then tell them a story, a real life patient story, they listen to you more. So I'll start with the story of a patient of mine who had juvenile rheumatoid arthritis. Piyush Bhai, yes, of course, forgot. And as you would know, juvenile rheumatoid arthritis can be devastatingly deforming, and especially the polyarticular subset of juvenile idiopathic arthritis. And a child, I remember the name, and we should not speak names, but I remember the name because, naam Lalu ji but it was Lal Prasad, I remember. And he came to me with severe joint pains and what looked like deformities, 6 months, 1 year duration, but the deformities had started setting in. And I started on disease modifying drugs, and I called him back after a month or two. And 3 મહિના પછી એ પાછો આવ્યો, and by 6 months on follow-up, his deformities had really reverted back to normal. And the father, he literally મારા પગે લાગી ગયો, આપણે વેદાંતમાં જ ઉપર, કે સાહેબ આમ તેમ. એટલે મેં એને બાજુમાં ખસેડીને કીધું કે તારા ફિઝિયોથેરાપિસ્ટનો નંબર મને આપ. This is magic by our physiotherapist. I still have that physiotherapist from Eder એનો નંબર મારા ફોનમાં, because the magic was done by the physiotherapist and not me. I knew that. And મેં એને કીધું કે this is by your physio, and I still retain that guy's number. He was so good. So, and then of course I myself had frozen shoulders and kind of, so I knew what physiotherapists are and how casually as rheumatologists we advise physiotherapy. It's a science, I knew, which I don't understand. So this is the second part. And the third thing is that, you know, we have a journal called Arthritis Care and Research, which is one of the publications of American College of Rheumatology. That entire journal is by an association called ARHP, American Rheumatology Health Professionals, which includes rheumatologists, physiotherapists, lab scientists, everyone. And एक article is full of these kind of original studies on kind of physiotherapy which has reversed, or you know, galvanic stimulation, those kind of things, or drugs, medications. એમાં guidelines અમારી latest આવ્યો તો એ બી આવે, કારણ કે everybody is supposed to read that. I think all of us need to evolve to that level. Each of you is a professional. You have to know, for physiotherapists who are dealing with rheumatologic diseases, for example, they have to know what the guidelines are, what the current recommendations are for the treatment of rheumatoid arthritis. And we have to do those kind of studies together to prove how physiotherapy can be useful. I think we have to get out of the hierarchy that we ourselves have made between doctors and physiotherapists and residents. VS માં તો પેલા છોકરા ઊભા થાય, હવે તો આપણે ટેવ પડી ગઈ છે બધા ઊભા થાય જ. એટલે એક દિવસ હું પાછો બાર પાછો ગયો, પાછો બાર પાછો ગયો, મેં કહું ઊભા થયા જ કરો તો મજા આવે છે. What's the point? I mean, I think we should get out of that hierarchy and treat everybody as a scientist and equal. But we need to do that, you know, to do those kind of studies to prove our words. So I think we need to get out of that trap. So with that brief background, I'll go on with my talk, which is, I thought the actual was pattern recognition for rheumatologic diseases in general, but I was told to talk on rheumatoid arthritis, so I'll stick to rheumatoid arthritis because the others might not be very relevant for all of you. And any students, so make the boot any, but young physiotherapists are, and I see almost everybody is younger than me, so all of you are young. Can just raise your hand to ask me a question. So this is going to be the profile of my talk. I have 5 cases which I'll be discussing one after another, just 2 slides on one case. So that's about 10 slides. And we'll have learning points from each. Then I need to show you one slide on what is called pre-clinical rheumatoid arthritis. I believe that all of you should have that kind of insight into rheumatoid arthritis if you're going to deal with rheumatoid arthritis. The differential diagnosis of the different patterns, there'll be just one slide on that to show what the different arthritis patterns are, and I'm sure many of you know about that. What is the future going to be? And as I see it, you know, I'll come to that later, that all of us, you know, this Sunday we are having a science club at NHL. I go to VS in the mornings and try to teach, share with my students what experience I have. And one of the talks is there is artificial intelligence and chat GPT and whether doctors are going to be obsolete. So I think just one slide on the future pattern recognition and then the key takeaways. So this was one very good line from New England Journal of Medicine, which said that the process of pattern recognition, so characteristic of an expert's approach, is a product of extensive experience with patients overlaid on a formal knowledge structure. It takes both kinds of knowledge to achieve success, and both are used by experts. Put simply, there is no substitute for experience, even the limited experience of novice clinicians. And that is something that I share with my students also. Okay, the eyes will see what the mind knows. If you don't know what palindromic rheumatism is, you will never make a diagnosis of palindromic rheumatism. So you have to keep reading to know that stuff, right? And then you gain that experience and you mix the two, and that's how you come out with clinical application of these things. So case number 1 is a 30-year-old lady. She comes to me with 2 weeks of illness, and she has pain and swelling of all finger joints and both wrists, significant early morning stiffness. And clinically, if it is more than 45 minutes, we take it as significant, because at old age and in winter, you can have a bit of morning stiffness even normally. An ESR is about 20, which is normal, and ASO is 300, the cutoff is 200, and the rheumatoid factor is strongly positive. The CCP also turns out to be strongly positive. What do you mean by strongly positive? And another thing that I would want all of you to know. અને હું આ વીએસમાં છું ને એટલે અંડર ગ્રેજ્યુએટ છોકરાઓ બી હોય, પછી ઇન્ટર્ન્સ બી હોય, પછી પોસ્ટ ગ્રેજ્યુએટ્સ બી હોય, અને પહેલાં મારા ફેલોઝ બી હતા. હવે ફેલોશિપ્સ અમે બંધ કરી છે. વી વિલ હોપફુલી ગેટ ડીએમ, બટ આઈ ડોન્ટ નો વેન. સો I tell all of them, okay, it's a continuum. You nothing can MBBS. He may know more than you. What's the big deal? Right? So all of you have to know this. You have to know the cutoff when you see a laboratory report. I need the cutoff. What is the normal cutoff? That's why I put in bracket. મતલબ છોકરાઓ કહે ને કે સાહેબ રૂમટોઇડ ફેક્ટર 27 આલા પણ કટ ઓફ તો કે કારણ કે જુદી લેબ્સમાં જુદું કટ ઓફ હોય. સો ઇટ હેઝ ટુ બી મોર દેન 3 times normal. You see the rheumatoid factor here is 100, which is 4 times. The CCP antibody is more than 12 times, so that becomes significant. If you have a CC antibody level of about 15 and the cutoff is 5, that's not a big deal, right? So I would go with my clinical diagnosis. So this is the story. Now, what's the diagnosis here? Anyone want to take a guess? What will be the diagnosis? Since CCP antibody is very specific for rheumatoid arthritis, we might call it rheumatoid arthritis. So what are the learning lessons from, and why did I put 2 weeks of illness? So basically rheumatoid arthritis diagnosis usually needs 4 to 6 weeks for, and more than 5 joints. You have more than 5 joints here, but you need more than 6 weeks. And initial criteria hata, 1980 ACR criteria was there because of rheumatic fever and other viral illnesses. Rheumatic fever, arthralgias normally don't last more than 4 to 6 weeks. Chikungunya arthritis acute will not last more than 2-3 weeks. You have chronic chikungunya arthritis, but in other viral conditions, you may get some joint pains for even COVID my lokone joint pains thayala, but that usually is 2 to 3 weeks, not more than that. So we would wait for that much time before we call it rheumatoid arthritis. Rheumatic fever arthritis usually don't last beyond 6 to 8 weeks. એટલે તમારી પાસે પેશન્ટ આવવાનું ફિઝિશિયન્સ અને બધાને હંમેશા કહું કે જેને 2 વર્ષથી આર્થરાઇટિસ છે તો ફોન પર બી ડાયગ્નોસિસ થઈ જાય, તમારે ASO મોકલવાનો કોઈ મતલબ જ નથી. ડોન્ટ સેન્ડ એની ASO. And then it will turn out to be positive, and then you will start penicillin prophylaxis. It doesn't mean anything. It has to be an inflammatory arthritis, right? ASO has to have a normal population cutoff. That's the other important thing. What is ASO? It's an anti-streptolizin antibody. તમે આપણે બધાનું ASO કરીએ અહીંયા તો મે બી 2-4નું પોઝિટિવ હોય. વોટ્સ અ બિગ ડીલ? ઇટ જસ્ટ શોઝ કે મને લાસ્ટ વીકમાં કે એના પહેલાં ડિપેન્ડિંગ ઓન IgM કે IgG ઇન્ફેક્શન થયું છે. ઇટ ડઝન્ટ મીન I have rheumatic fever. So a lot of normal things that you have to know. While rheumatoid factor may be more sensitive, as all of you know, CCP is very specific. What does it mean? It means that you might miss some of the rheumatoid arthritis if you do only CCP antibody. But if you have a CCP antibody which is strongly body, it has to be rheumatoid arthritis. There are other conditions like tuberculosis and some where you might get CCP positive, but by and large, if you have a background of polyarthritis and you have CCP antibody positive, it is rheumatoid arthritis. And that's why I agree with you that this patient with 2 weeks of arthritis, with these kind of fingers, with CCP strongly positive, I will probably not wait for 6 weeks and start the treatment for rheumatoid arthritis and then see how she goes or he goes. તમારે તો પહેલે દિવસે ફિઝિયોથેરાપી ચાલુ કરી દેવી પડે. That is period. So these are the criteria for rheumatoid arthritis. I won't go into the details, but those are the markings which are ACR 2010, which are the latest. I suppose they'll be revised soon in the next couple of years. That's just to go through what the points are, and you have to have more than 6 points to call it rheumatoid arthritis. Now case number 2 is a 25-year-old lady. She comes with 6 weeks of joint pain. So now I've made it 6 weeks, so there is so there is still confusion. Fleeting in character. She has a CRP which is, so what is the normal cutoff? 6, and this is significantly more, right? So that's how you interpret investigations. An ASO of 450 with a cutoff of 200, a rheumatoid factor of 25 with 20 cutoff, so that's not a big deal, and a CCP is negative. And the 2D echo, because the physician thought of rheumatic heart disease, did an echo which is normal. These are the Jones criteria for rheumatic fever. Now what is the diagnosis here? CRP high, ASO high. If you look at the criteria, you have to need 1 major or 2 minor. So you have arthralgias here, you have actually arthritis, and you have an increased CRP. So 2 minor thing, yeah, but you need 1 major. And we have polyarthritis, but if you call it arthritis, so it still doesn't fulfill the criteria. Now, the other thing you need to remember, I'll be coming to that in the next slide, is epidemiology is very important while considering the diagnosis of a disease. And Amit to pacho mari next generation no થઈ ગયો. પણ મારી જનરેશનના જે સાહેબ નીકળી ગયા, we used to see a lot of rheumatic fever and rheumatic heart disease. I remember I did my MD at Shardaban Hospital, and every other patient was diagnosed as rheumatic heart, mitral stenosis, mid-diastole, rumble and all of that. Now rheumatic fever is on the decline because rheumatic fever is spread by streptococcal infection where close by people live. We still live close by, but we are now much better than what we were before. So the prevalence is now, the incidence is now lesser. So you have to remember the incidence and the prevalence and the age of the patient when you diagnose a condition. The other thing you need to remember is that classification criteria are for inclusion in clinical trials. They are not for a bedside diagnosis. ગઈકાલે મારો એક એમડી રેઝન કહેતો હતો કે સાહેબ આમાં ક્રાઇટેરિયા ફૂલફિલ નથી થતા. સો આઈ એક્સપ્લેન ટુ હિમ કે આપણે ટ્રાયલમાં ઇન્ક્લુડ નથી કરવાના. ઇફ યુ વોન્ટ ટુ ઇન્ક્લુડ ઇન ક્લિનિકલ ટ્રાયલ, જેમ આપણે એવરોનમાં થાય છે બધી ટ્રાયલ્સ, then they need to fulfill those criteria. But otherwise, and most of the diseases don't have diagnostic criteria. So you make a diagnosis based on your clinical judgment. In borderline doubtful cases, better not to give DMARDs and manage the pain. This is more for rheumatologists and physicians than for physiotherapists. But so when in doubt, you can wait for some time instead of, in private practice, we all feel very answerable to our patients, which is not so. Science remains the same. તમે પ્રાઇવેટ પ્રેક્ટિસમાં હો કે ગવર્મેન્ટ સેટઅપમાં હો, ગવર્મેન્ટ સેટઅપમાં તમે નાપ્રોસિન આપીને જાઓ, અહીંયા તમને લાગે કે આને કંઈક આપી દીધી સારું થાય. But you just explain to them in detail and they'll be fine with it. You have to give more time to them. So that's the thing. And this is the difference between diagnosis and classification criteria. That's for groups. For an individual, those are very specific, while these are more sensitive. So that's the difference between diagnostic and clinical and classification criteria. Case number 3 is a 45-year-old lady. She comes with 2 years of joint pains, which are migratory. And what do you mean by migratory? કે એક જગ્યાએ થાય પછી નીકળી જાય પછી બીજી જગ્યાએ થાય, as against additive, which is one on top of another. So a patient tells you કે મને જમણા ઘૂંટણમાં દુખાવો શરૂ થયો સાહેબ 2 વર્ષ પહેલાં તો ઘણી વાર યાદ નથી, 6 મહિના પહેલાં, અને 2 દિવસ રહ્યું અને પછી જતું રહ્યું, અને પછી મહિના પછી મને લેફ્ટ એલ્બો પકડાયો અને એમાં સ્વેલિંગ ને પેઇન થયું, પછી પાછું 2 દિવસમાં એ બી જતું રહ્યું અને પછી શોલ્ડર પકડાયો. That is migratory. But if the patient says કે સાહેબ મને જમણા ઘૂંટણમાં દુખાવો થયો અને સોજો થયો અને એ શરૂ હતો અને મને લેફ્ટ નીમાં બી થઈ ગયો, that is additive pattern. There's a difference, right? So palindromic is migratory, pain and redness and swelling, no deformities, normal examination. You see that figure that shows that redness. This is the kind of redness they have. The ESR is high, the CCP is positive, but what is the cutoff? 15. So it's just about twice, so I won't give it much importance. The rheumatoid factor also is just about twice normal. So what's the diagnosis here? This is palindromic rheumatism. That's why I'm saying. Now this is the term I learned at SGPJ only. I didn't know before. પહેલાં તો rheumatoid arthritis બી નહોતું આવડતું. That also I learned at SGPJ. But palindromic rheumatism is a condition. I have missed that on my own. There have been these young girls, which Amit must have referred so many cases to me, કે એને મારી પાસે આવે અને આપણે પૂછીએ અને આપણી પાસે આવે ત્યારે એકદમ નોર્મલ હોય. I remember definitely 2-3 young girls. અને the CCP is 200 with a cutoff of 5. અને she tells me joint pains થાય છે અને પેલી આપણે ઉતાવળમાં હોઈએ ને એ વખતે તો કેટલા 5 મિનિટમાં 10 મિનિટમાં બહાર પેશન્ટ, રાઈટ? સો ભાઈ કંઈ નથી, તમે આ દવા લો અને પછી આવજો, કાઇન્ડ ઓફ થિંગ or whatever. Then I learned palindromic rheumatism. And the one patient came with a photograph. So I said, this is definitely inflammation. So now I ask them to take photographs, and if you ask them in detail, they will tell you, problem is, and again I tell my residents, કે એટલી પેશન્સ જોઈએ ને એટલી તસદી લેવી પડે પૂછવાની પેશન્ટને કે તમને અહીંયા દુખ્યું ત્યારે લાલ થયું હતું, સ્વેલિંગ થયું હતું, તો પેશન્ટ કહે છે સાહેબ એટલો બધો દુખાવો થાય છે કે આમ બી નથી કરી શકતી એમ. That is palindromic rheumatism. The pain is very severe in PR, but it goes away. So when the patient comes to you, she is fine, but she has had that history of pain. So this is PR. I have found in my cohort of patients, group of patients, CCP to be strongly positive in palindromic rheumatism. Interestingly, my colleague in Kerala, who has about 250 patients, but I have about 350 patients of palindromic rheumatism, and I keep my data, he doesn't have that much of CCP positivity. So there seems to be some difference in the patterns in different parts of the country, and that is why we need to study that. Okay, why is it so? Okay, Gujaratis or whatever patients we see, but largely Gujaratis have CCP positivity. But this is palindromic rheumatism. Learning points from this is a lesser known entity. I don't think very many of you or even doctors know about this, but you should know. Ask for that before labeling patients as fibromyalgia, because I myself call that girl fibromyalgia and hypermobile syndrome. તમને કંઈ છે નહીં, પછી એને મારા દેખતા જ થયું એટલે આ તો PR છે. The other thing to remember is that palindromic rheumatism evolved into rheumatoid arthritis in the future, so you have to treat them. PR can evolve into other connective tissue disease or vasculitis. I remember one lady who came to me with palindromic rheumatism, and then 6 months into her disease, she evolved into a vasculitis. Sonal Ben, she had renal involvement, and Sonal Ben was kind enough to tell me that she has turned out into a vasculitis. So these patients can evolve into other diseases also. Laboratory test results don't seal a diagnosis or rule out always. So it has to be clinical. The CCP may be negative in palindromic rheumatism, you still call it PR. So, and that is some people are trying to bring in criteria for palindromic rheumatism, but they have not yet come around. and my colleague in Kerala, and we are planning to come out with the criteria for paranormal based on the data we have. You might see some kind of criteria from Indians sometime from. We are really hoping to do that. So the next case, and this is the second last case, is a 50-year-old lady. She comes with 5 years of duration of inflammatory deforming polyarthritis. She has an ESR which is high, a rheumatoid factor which is positive, a CCP which is just about the cutoff. And the X-rays here you can see. You can see the erosions there, maybe, right? You can see the erosions. And so in these situations where you are almost sure of the diagnosis of rheumatoid arthritis, and if the serology is negative, then you do X-rays of the hands and that will show you erosions. Erosions are very specific for rheumatoid arthritis. So what are the learning points here? Ranging from different studies, about 15 to 20% of rheumatoid arthritis can be seronegative. Now CCP antibody is a very specific test for rheumatoid arthritis, but it is not very sensitive. So about 60% cases में positive आवे, 40% केस तमे miss करो जो तमे खाली CCP antibody कराओ तो. Rheumatoid factor sensitivity is about 75%. So it's slightly more than CCP, but it's not very specific. So rheumatoid factor આપણામાં भी normal, આપણામાંથી આટલાનો કરાઈશું તો કોકનું positive આવી જાય, doesn't mean anything, right? So, but what I'm saying is that if the CCP and rheumatoid factor is negative, it does not rule out rheumatoid arthritis. This patient with inflammatory polyarthritis deformities for 5 years is rheumatoid arthritis for all practical purposes, right? So X-ray erosions, especially at hand joints and wrists, are quite specific for rheumatoid arthritis and they correlate with the functional status of the patient. Role of physiotherapy, much more in these along with medical management. All of you know, these are the cases that, and this is a photograph which shows stage 1 and then 5 years into disease and 10 years, 15 years of disease. Now this was a situation we were seeing till now. પણ હવે જો પેશન્ટ આપણી પાસે લેફ્ટ સાઈડવાળું આવે તો આપણા બેની ફરજ છે કે રાઈટ સાઈડમાં ના જાય. I mean, we try our best and you still have some patients who will still go, but you treat appropriately and all of us together have to see to it that they don't have a functional decline. The last case is a 65-year-old gentleman who comes with 22 years of duration. So with diagnosed case of rheumatoid arthritis and there are deformities, no early morning sickness for the last 2 years. The acute phase reactants have become normal now and the serology still stays positive. These are the patients who will have these extra-articular complications like the one you are saying. And these are the patients that Amrit would have maximally referred to me because they start getting CNS vasculitis. Or this is a vasculitic ulcer on the leg. Our patients tamari પાસે બી આવતા હશે જેમને non-healing ulcers થયા કરે legsમાં. They are known cases of rheumatoid arthritis. So these are this is rheumatoid vasculitis. Sometimes it could be pyoderma gangrenosomosum. These are extra-articular complications of rheumatoid arthritis. And very interestingly, જ્યારે rheumatoid arthritisના patientsને pain અને stiffness ઓછી થવા મળે clinically ત્યારે એમને extra-articular manifestation, which is dry eyes, dry mouth, interstitial lung disease, vasculitis, those kind of things. So those are, અમારી પાસે patient આવે તો અમારે આ બધું પૂછવું પડે એમને. Patients don't tell you, you have to ask them. So learning points from this concept of burnt out rheumatoid arthritis. Earlier we used to believe that there is burnt out, કે અમુક વર્ષો પછી burn out થઈ જાય. એ તમારી પાસે આવે તારું બધું નુકસાન થઈ ગયું પણ હવે કંઈ બહુ મેથોટ્રેક્સેટ આપ્યાનો મતલબ નથી. We hand over to the physiotherapist. હવે તમારો જ વારો છે, અમારું કામ પતી ગયું છે. Many people believe there is nothing like burnt out. Internally એ લોકોને હોય છે, પણ we see those cases. The concept of window period, which is shown on the right. So the orange line is inflammation and it goes down with time. And the blue line is disability that increases with time. And this is the radiograph which keeps worsening. So this is the window period. This is the period when you'll have to treat. The first 2-3 years of the disease are going to be very vital. એટલે હું પેશન્ટ્સને એવું સમજાવું કે આ 2020નો મેચ છે, પહેલાં 5 ઓવરમાં રન નહીં બનાવો તો પતી ગયું, પછી આસ્કિંગ રેટ વધતી જ જશે. So it's the same for rheumatoid arthritis as well. And the concept of sarcopenia is now coming, and I think this is a state where all of you are going to be very important. We need data of sarcopenia in India. And the way to measure it is by doing DEXA scans, which will give you the muscle. Somebody from the medical college in the physiotherapy department or even private, why should we depend on just medical college? I mean, nobody like Atul Patel is an example. જે private આટલી બધી research કરે છે. Who else does it? Publication છે સાહેબનો દર મહિને. So he shows that you don't need to be medical college to do science. You can do in private also. But we need data of sarcopenia in India. We really don't have data. So somebody has to have normative data first, કે normal aging જોડે sarcopenia કેટલું રહે છે, પછી diabetics માં કેટલું છે, rheumatoid માં કેટલું છે, that kind of thing. And atherosclerosis, osteoporosis become more important this stage. And Danish will excuse me when I say that I tell my doctor colleagues and જ્યારે orthopedics ના બેઠો ને audience માં ત્યારે કે this is how we look at patients differently from orthopedics. Orthopedics are the cutest community I have seen. એ લોકોને ખાલી સર્જરી જોડે જ મતલબ હોય એટલે એ લોકો પેશન્ટને જનરલી ક્રોસ સેક્શનમાં જુએ. આજે શું કરવાનું છે કહી દો. અમે લોકો જોઈએ તો 10 વર્ષનો વિચાર કરીએ એમ કે અને 5-10 વર્ષ પછી એથરોસ્ક્લેરોસિસ ના થાય અને કોરોનરી આર્ટરી ડિઝીઝ ના થાય, યુ નો, અને ઓસ્ટિયોપોરોસિસ ના થાય. ઓર્થોપેડિક્સ બહુ ક્યુટ, એ લોકો અત્યારે ટ્રીટ કરે, they don't bother. And generally they send them to you કે ભાઈ હવે માથું તમે સપનભાઈનું ખાજો ને અથવા બીજા રૂમેટોલોજીનો દો. બટ so orthotics is something I've not seen very developed in Ahmedabad, unfortunately, and some of you needs to pick that up. I don't think we have anybody doing good orthotic splints and all that science. I don't know, somehow patients are not very happy. And physiotherapy is most important at this stage, right? So, and then of course adverse effects of drugs, of steroids over long term, osteoporosis, BMD, DIXA scan, and those kind of things are going to be important this year. So that completes those 5 cases. This is one slide I want you to know, because this is again something that, you know, maybe orthopedics should try and listen at least, is that now this is the point where the patient starts getting seropositivity. Every autoimmune disease, remember, this is the point when the patient comes to you and a full-blown rheumatoid arthritis થઈ ગયું. This is the point probably 2-3 years before the full-blown arthritis when the patient started having what is called palindromic rheumatism, or એક બે joints ચાલુ થયા, symptoms. અહીંયા એને symptoms ચાલુ થયા, pain and stiffness. This is where the rheumatoid factor CCP got positive. So it begins much earlier. What I'm trying to tell you is, when the patient comes to you, એના લોહીમાં તો લશ્કર 10 વર્ષથી રમતું હોય. So CCP positive, rheumatoid factor positive, તમારી પાસે આવે પહેલી વાર તો એને rheumatoid factor અને CCP positive 5-7 વર્ષથી હશે, પણ એને સિમ્ટમ નહોતું થયું. એટલે જ્યારે સિમ્ટમ થાય, and not everybody gets. Some people get only rheumatoid factor positivity. They never get symptoms. We don't know why. And some people don't even get rheumatoid factor positivity. So that all, this is what preclinical rheumatoid arthritis is about. We are still debating in rheumatology and immunology whether we should treat simply blood reports. And as clinicians, we will never treat blood reports. But the research scientists, they look away who say that maybe rheumatoid factor CCP positivity hoy, so you can give them something like hydroxychloroquine, which will prevent further disease development. But as of now, as clinicians, we will always wait for a symptom, because we will never treat lab reports. But when you see a lab report, you have to know, can a 5 વર્ષથી બધું ચાલે છે અને આજે મારી પાસે આવ્યા છે. So according to that, you have to have that insight in you. That's why this slide. You know, one of my friends, આપણે શિશુ સાહેબ અમિત ઓળખે છે, હંમેશા કે ડીએમ ને એમડીમાં ફરક શું છે? मैं डीएम करूँ तो શું તો क्या हो गया साहब, तू बड़ा आदमी हो गया, क्या डीएम कर लिया तो क्या हो गया, આપણે શ્રેયમાં હતા ને સાહેબ. So all that a doctorate gives you is more insight into the disease. બાકી દવાઓ તો એમડી બી ઘણી સારા, they are sometimes they are even better than DMs, because they have developed that wisdom over time, but it gives you a better insight. So you have to have that insight into the disease, right? Now this is a very important, the most important slide probably for differential diagnosis. So the first is what you see, the joint distribution. Inflammatory polyarthritis of almost all joints, big and small. So this is what is the diagnosis? This is rheumatoid arthritis, right? The second, if you look at the pattern, can you see here one toe which is involved? The red one. Then there's one ankle. Then you have asymmetrical distribution. What is this? Very, psoriatic arthritis, right? So that is called dactylitis. When you have a single toe, it ઘણી વાર પેશન્ટના ટોઝ ને ફિંગર્સ તમે જુઓ તો એક આમ સોસેજ જેવું લાગે. ઇટ્સ કોલ્ડ સોસેજ ડિઝીઝ. સો આસ્ક ધ પેશન્ટ ફોર સોરાયસિસ એન્ડ દે વિલ ટેલ યુ કે હા મને કાન નહીં, પાછળ ને વાળમાં ને ફર્સ્ટ દે ટેલ યુ કે ના ના કશું નથી. દેન યુ લુક એટ યુ એન્ડ હાફ ઓફ ધ ડર્મેટોલોજિસ્ટ વિલ સે it is not psoriasis, and I tell them forget the dermatologist, this is psoriasis. The pattern is psoriatic arthritis. So this is psoriatic arthritis, remember. Then this is, look at the distribution, you have one knee, you have the whole back, ankylosing spondylitis, right? And the sacroiliac joint. So this is ankylosing spondylitis. That's a whole another lecture which I may take someday. Somehow the favorite test has become HLA-B57. 1500 નો ટેસ્ટ છે. It doesn't diagnose anything. The diagnosis by simple X-ray of the sacroiliac joints or an MRI magnus. I almost મેં કેટલા B27 ઓર્ડર કર્યા છે મારી પ્રેક્ટિસમાં JK ને તો ખબર છે જગદીશભાઈને hardly ever. In an year, I order not more than 5 HLA B27 because sometimes in a child I have to do that. Otherwise, I am very clear about my diagnosis, and you also should be very clear about your diagnosis. I am sure Dinesh Mani will agree there. Yeah, he will agree. And this is, look at the distribution. You have first MCP on both sides, both knees, first toes, first MTPs, and you have sometimes the spine. First MCP and knee is osteoarthritis. Yes, so this is osteoarthritis, right? Many patients are referred to us with osteoarthritis. Some of them have DIP joint osteophytes and PIP joint osteophytes. They are called Heberdin's nodes and Bouchard's nodes. If you ask them, they tell you કે સવારે જકડાપણું થતું જ નથી એમ પેન જ થાય છે. The ESR is normal, the CRP is normal. Rheumatoid factor say 25 positive, 21 allopathy. They are labeled as rheumatoid arthritis, but this is simple osteoarthritis. So this is clinically the most important slide for today's talk. And this is what the pattern recognition is going to be in the future. અત્યારે આપણે અહીંયા છીએ, so આપણી પાસે પેશન્ટ આવે છે, આપણે phenotype, but this is going to be the genetics. So what will happen, and you have artificial intelligence and machine learning coming in. હું ઘણીવાર એનાલોગી આપું કે મને લાગે છે કે ફ્યુચરમાં એવું થશે કે તમે અમેરિકા ગયા હો તો પેલા સિક્યુરિટી સ્કેનમાં તમારે ખાલી ચાલીને જવાનું, રાઈટ? એ પેલું મશીને બધું ચેક કરી લે ને પેલું ટૂ કરે તો આમ ને નહીં થ્રુ. I think clinical science is going to become like that. There will be this whole machine thing. You go into that machine, you give a sample, બહાર નીકળશો એટલે ટક 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 તમને ડાયગ્નોસિસ આપી દેશે કે આ તમારી 15, 20, 25, 30 ડિફરન્શિયલ ડાયગ્નોસિસ ડિપેન્ડિંગ ઓન ધ ફર્સ્ટ and also your blood test, it will tell you the diagnosis. So આપણી ઇમ્પોર્ટન્સ શું રહેશે તો પછી આપણી ઇમ્પોર્ટન્સ રહેશે to engage with the patient. You will still have to talk to them. You will still have to ask them, talk to them about the disease, be empathic to them. I think that is what is going to remain with us. And physiotherapists, those who are driven patients, they will look at videos and do that. But otherwise, you will have to give them the drive to do that. I think that is where physiotherapy will be more important than clinicians. કારણ કે તમારામાં એવું ના થાય કે આમ મશીનને કરી દીધું ને એક્સરસાઇઝ થઈ ગઈ. એ તો દર્દીએ જાતે જ કરવી પડે. So you are still going to be very important. And I think this is what, to cut the long story short, I think science is going to change like anything 10 years from now. અને હું છોકરાઓને બધાને નેક્સ્ટ સેટરડે સન્ડે મેં એના માટે જીનોમિક્સની વર્કશોપ રાખી છે VSમાં. And the guy who is coming is the guy who has sequenced the first human genome in India. અને એ તો એટલે આવે છે કે એની વાઇફ રૂમેટોલોજિસ્ટ છે, નહીં તો ના આવે. પણ મેં એની વાઇફને લખ્યું કે બોલાય પેલાને. So, and I told the students, you'll have to learn genomics. છોકરાઓ વાંચતા નથી. મેં કીધું તમારે મારે ચાલશે, તમારે નહીં ચાલે. અમિતને ખબર છે કેટલું જેનેટિક્સ છે એ લોકોને. Every other patient they order whole genome sequencing. We will have to know this science. And that is how phenotype is going to be. The pattern recognition is going to change. This is the pattern that is going to come out. All of the young crowd will have to read that stuff. You are into science, you are a part of medical community, you will have to read it. At least the youngsters तो नहीं चाले. हमारे जान तो ये चाले कि बहुत गई ने थोड़ी रही. So what are the take-home messages from here? Clinical pattern recognition still stands the test of time as of now. Any inflammatory polyarthritis more than 6 weeks involving more than 5 joints should be managed as rheumatoid arthritis, right? It may be seronegative, it doesn't matter. Laboratory parameters help in validating the clinics. About 20 to 30% patients can be seronegative for rheumatoid factor and whole 40% can be negative for CCP antibody. Negative RF-CCP does not rule out rheumatoid arthritis, but a positive CCP usually confirms rheumatoid arthritis with few riders because some cases of tuberculosis and psoriatic arthritis may have CCP positive. But you have to have a clinical diagnosis, of course, first. Healthcare providers should be aware of the window period and manage accordingly. By healthcare providers, I mean both I and you. We are a part of the same team. We have to be aware કે જે આપણે કરવું હોય પહેલી 5 ઓવરમાં કરવાનું છે. અમારે ખાસ 5 ઓવર પછી તમારો તો રોલ પછી બી રહે 15મા ઓવરમાં, પણ અમારો રોલ મેઇન 5 ઓવરમાં જ રહે. And we have to see to it that they don't land up with deformities. Physiotherapy starts from day 1 of the diagnosis, of course. I don't think there is an option to physiotherapists, and somehow that is a science which as I must accept with full humility that as rheumatologists especially, and I think orthopedics there are much better. They always involve physiotherapists with all there. But we somehow are not still we take physiotherapy very casually, and I think all of us need a team of both physiotherapy and rheumatologists to manage these patients well. It's like a husband and wife, you have to, the marriage takes time. So I think the last day I'll just say that it takes time. It takes time, for learning things, for knowing things. And I'll just end again. I started with Dhan Tejasvi's, and I'll again end with that. કે ભલે આર્ટિફિશિયલ ઇન્ટેલિજન્સ આવે, ચેટ જીપીટી આવે, પણ કર્તવ્ય વગર સુખ છે એને ક્યાંથી લાવશો? તમને દુઆ તો મળશે, પણ અસર ક્યાંથી લાવશો? શિવની જેમ નાગનું મફલર તો બનાવી દેવાશે, પણ ઝેર પીવાનું જીગર ક્યાંથી લાવશો? એટલે એ તો આપણે ડૉક્ટર્સ જ કરવાનું છે, રાઈટ? ઓલ ઓફ અસ ટુગેધર હેવ ટુ ડુ દેટ. ભલે એઆઈ આવે ને જીટી, દેટ ઇઝ સમથિંગ દેટ વીલ હેવ ટુ ડુ. Thank you, ladies and gentlemen. I'll be ready for any questions. Yes, please. Is somebody going to monitor that, or I'll do that? Yes, please. આપણે ટાઈમ કેટલો છે જોવાનો?
હેલો સર. સર એક ડાઉટ છે રિગાર્ડિંગ લેબોરેટરી ટેસ્ટ. સર હવે મારું હું તમને રિસન્ટ એક્સપિરિયન્સ કહું તો મારો એક પેશન્ટ છે, એને વિટામિન D3 બહુ જ ઓછું આવે છે અને રિપીટેડલી ફિઝિશિયન એમને એડવાઇસ કરે છે કે એવરી 3 મંથ તમે D3નો રિપોર્ટ કરાવડાવો. એન્ડ ધ થિંગ ઇઝ દેટ કે પેશન્ટને સિમ્ટમ્સ એવા છે નહીં, વાય દે આર ડુઈંગ ધીસ સચ થિંગ્સ. અને અનધર થિંગ ઇઝ દેટ કે મેં હમણાં જ એક રિસર્ચ વાંચ્યો હતો આર્ટિકલ, એઝ યુ આર અ પર્સન કે જે રિસર્ચમાં વધારે ઇન્વોલ્વ છો, તો
પ્રેક્ટિસ બી કરું છું.
હા, યસ તો આઈ કેન આસ્ક યુ ડાયરેક્ટલી કે સર એમાં એવું છે કે D3ના ક્રાઇટેરિયા લાઈક કન્ટ્રી અકોર્ડિંગ અલગ અલગ હોઈ શકે, બિકોઝ આપણે સનનું રાઇઝ લાઈક વધારે મળે છે અને વી હેવ અ મોર ઇફેક્ટ્સ ઓફ ઇટ. તો પછી D3 કેમ ઓછું આવે છે? સેમ ફોર ધી અધર ડાયગ્નોસ્ટિક ટુ. તો આપણે ટ્રસ્ટ કરવા જેવો કે નહીં આના?
So the answer to your second question is more difficult than the first one. So I have ordered about 1 vitamin D in the last 1 year, just 1 case or 2 cases, not more than that, in my patients. અને જે કે બિચારા થાકી ગયા નવી કિટ લાયા, મેં કહું સાહેબ હું તો જે રીતે ઓર્ડર કરું છું એ રીતે જ કરીશ. I simply don't order vitamin D because number one, most of us are going to be deficient in vitamin D. 80% of the world is insufficient in vitamin D. It is very well known, and about 10% are deficient. So you simply treat. 25 OHD is what? 1500 tests again? What's the point? And you order a 25 OHD, not vitamin D3. There is a difference. 25 bracket માં OH and a D. That is the way you order vitamin D. Now, so why we sometimes order it, why I've ordered it is in a very rich patient, જેને fibromyalgia હોય અને માનતા ન હોય શું છે તો વિટામિન ડી કરાવો, મને ખબર છે ઓછું જ આવશે, પકડાઈ ગયું. મેડમ મને લીધે જ છે તમને.
Yes, exactly.
That is the only case where I order, otherwise it's not needed. I don't think you need 3 monthly vitamin Ds. You simply treat them effectively. And to answer your second question, well, the world over the vitamin D levels are going to be same. And why we have low sufficient, I don't have an answer to that, because we have more sun exposure. Probably something in our gut or probably in our skin, maybe Danish by nose, but I think, yes, you are right, we are deficient. I myself, મારું લેવલ જ 8 આવ્યું હતું, એકવાર કરાવ્યું હતું, એટલે પછી મેં એનો કોર્સ કરી લીધો, but I didn't bother to do it again. But we have low levels. I think it's something in the gut microbiome and also in the skin which causes that the vitamin D levels to be low. Yes, please.
આપણા કન્ટ્રીમાં સનલાઇટ વધારે છે, પણ તમે સનલાઇટને ક્યારે એક્સપોઝ થયા? આપણા બાપ દાદા ખેતી કરતા, સવારે 7 વાગ્યાથી સાંજના 7 વાગ્યા સુધી સનલાઇટમાં રહેતા હતા. ઇવન તમે 2 વ્હીલર લઈને જાઓ છો તો પણ યુ આર કવર્ડ.
Yeah, that's also
રાઈટ. સેકન્ડ થિંગ ઇઝ આપણી જે બધી કારના જે વિન્ડશીલ્ડ જે બધા ગ્લાસીસ છે દે આર UV પ્રોટેક્ટેડ.
Yeah,
so you are
ultraviolet
not
radiation.
getting proper sunlight,
Yeah.
which is required, right?
I think we'll let the other lady ask because otherwise you.
Yeah, so one another question. મારા રિલેટિવ્સ છે, લોકો ગામડામાં જ રહે છે એન્ડ દે આર એક્સપોઝ ટુ ઇટ. બરાબર, તો હવે એની માટે મને કોઈ ઓપ્શન નથી દેખાતો, બિકોઝ મેં એમનો બી રિપોર્ટ કરાવડાયો, મેં એમને બી કરાવડાયો કે ડુ ઇટ, એમનામાં બી ઓછું
So
આવે
I
છે.
Dennis ji એટલે હું ના બોલ્યો.
Other factors also.
So there is data by Vivek Arya. If you know Vivek Arya, he is a DM endocrine from Ahmedabad. He was with me at SGPGI. He did an official study and who published studies of vitamin D levels in SGPGIs. SGPGI are doctor or staff, and 80% of them were still low with all this sun exposure and everything. So it is low. It is very well known. I think it is something in the gut microbiome which is causing. The other thing is also depends on, as he said, the ultraviolet radiation. So winter માં for example somehow વધારે હોય છે અને આપણે ત્યાં કદાચ રેડિયેશન ઓછું હશે એને કારણે
In
કદાચ
summer too.
Yeah, maybe that's the reason.
And we have seen the complication of vitamin D3 deficiency also, particularly Muslim ladies
At
with
the
burqas.
later age, at the late.
Just yesterday only one patient was there, bilateral iliac crest stress fracture. Young lady, 25
Losers,
young
they are
lady.
called loser zones.
Yes.
Osteomalacia,
Yes,
yeah.
sir.
So to answer your question, don't get it done, just treat. અને આવા બહુ રિચ પેશન્ટને માનતા ને એમાં કરાવી દેવું, બાકી બહુ પડે. It'll be good if you identify yourself, because
Good afternoon, sir. It was very informative one. I'm having multiple questions.
can you
Sir,
identify yourself?
Sir, I'm Dr. Heta Kotak, and I'm currently working in Health One Physiotherapy Super Specialty Hospital as a consultant physiotherapist. Sir, my first question is, does there is a scope that in future we will gonna have any vaccination for the RA, because it is an autoimmune disease and every single system of your body is getting involved.
So fortunately, the vaccines in rheumatoid arthritis have not worked.
Okay.
Fortunately for us, I mean, people have
Okay.
tried. There are trials. They are called oral tolerogens. People have tried oral vaccines. You're very right, but it has till now those trials have not worked.
Okay. So second question is, as you explained, seropositive and seronegative RA. Sir, basic main difference between that and what are the symptoms? Does the symptoms are getting altered if the patient is having seropositive RA or seronegative RA?
So that's an interesting question. So in the short run, no, but most of the extra-articular complications, like you see rheumatoid nodules or you see rheumatoid vasculitis, that happens in patients, or erosions on the X-ray, that usually happens in patients who are seropositive. જે લોકો seronegative હોય, એ લોકોને usually એ બધું ના થાય.
Sir, which are the specific or reliable tests nowadays for the diagnosis of RA?
Clinical history taking.
Okay, that is the main one. And sir, one last question. As you explained, relapse patients માં થતું હોય છે that patient is stable since 1 to 2 years on DMA RDS, and suddenly again patients are getting symptoms and NTCCP is also getting higher. Then clinically symptoms are also there, stiffness, fingers pain and all those things. Then still we need to go for any other test, or what do you suggest?
So to the answer previous question, the other specific test is CCP antibody, which is quite specific, but I have seen an occasional case where I myself have diagnosed wrongly. I remember distinctly a young, not a very young lady, a young to 52, she was about 48. She came from Kutch, she had monoarthritis of the left knee, she was CCP strongly positive. I treated her as a rheumatoid. She went to a senior rheumatologist in Mumbai who used to come here, so all of you would know who he was. Fortunately, I was friends with him, so he gave me the feedback. And he got the biopsy and that turned out to be tuberculosis. So occasional tuberculosis cases can be CCP positive. But to answer the second question, if you feel a clinical flare, the only test that helps is a CRP or an ESR, which will usually be high in those patients. You don't need to monitor CCP and rheumatoid factor. Those are only for one-time diagnosis. You don't monitor them later on.
Sir, CRP and ESR is normal and NTCCP is high then?
CCP તો ડાયગ્નોસિસ માટે હતું, એ તો પહેલાં જ કરાવી દીધું, તમારે ફરી કરાવવાનું ના હોય.
Okay.
So if the CRP ESR is normal, but the patient has a clinical flare, then it's a flare. It is sitting in front of you, so you don't bother.
Okay, thank you so much, sir.
Any other questions? Anybody else? Bolo sir.
Sir, any preventing things like any role of immune modulation in form of yoga, meditation, or any homeopathy related role in your
Homeopathy, I really don't know, because I don't, I have not studied that. I wouldn't know. I'm actually quite pro allopathic, so I usually don't advocate the other pathis, especially Ayush. But yes, there are studies where people have shown that yoga has helped. Even Tai Chi has helped. In fact, in one of the American College of Rheumatology's, very ironically, આપણે કરવું જોઈએ, પણ yoga and Tai Chi in rheumatoid arthritis was one of the plenary papers.
Yes, sir.
અને પેલા ગોરાઓ પ્રેઝન્ટ કરતા હતા અને આપણે સાંભળતા હતા. So what those studies have shown that it is useful as an adjunct, but you still need to treat them with disease modifying drugs. But it together with that it does well. So yes, you can advocate that in those. Yeah, so well, there are no studies to that, but most of the times અમે લોકો પેશન્ટને એવું કહીએ કે તમારે એટલીસ્ટ 2-3 વર્ષ તો દવા લેવી જ પડશે. In those who are very early, they have come to you with 4 to 6 weeks, maybe you might be able to stop them in them, but most of the patients, especially those who are seropositive, મેં કીધું ને કે seropositive હોય તો એમને કેટલા વર્ષોથી હોય? 5-7 વર્ષથી હોય, એટલે જલ્દી નીકળે નહીં. Those B cells are going to be there. So interestingly, people have done bone marrow transplants in these patients. કારણ કે તમે બોન મારો ટ્રાન્સપ્લાન્ટ કરી લો તો તમે આખું એનું, કારણ કે રૂમેટોઇડ ફેક્ટર ક્યાંથી આવે? બી સેલ્સમાંથી આવે. બી સેલ્સ આખા બદલી દીધા, પણ તો બી એ લોકોને જો ઓટોલોગસ ટ્રાન્સપ્લાન્ટ હોય પેશન્ટનું તો એ ગોટ ધ ડિઝીઝ બેક આફ્ટર 5 to 10 years. તમે એલોજેનિક ટ્રાન્સપ્લાન્ટ કરો તો ક્યોર થઈ જાય, પણ એલોજેનિક ટ્રાન્સપ્લાન્ટ has a mortality of about 25%. So who will be ready? And the cost is about 20 lakhs. So who will do that? So to answer your question, most of the patients will need long-term, if not lifelong treatment, but about 20-30% you might be able to take it off. Any other questions? Okay, thank you.
Thank you very much, Sapan sir. That was a wonderful session. And it's great to see so many questions coming from you guys. Our next speaker, Dr. Amit Bhatt. He is a highly regarded neurologist with more than 2 decades of experience in the field of neurology. He is an expert in thrombolysis, movement disorder, stroke, and epilepsy. I'd like to welcome Dr. Amit sir.
Thank you and good afternoon to you all. Today I am going to speak on Parkinson's disease and red flags. It's a very vast topic, so my focus is mainly on symptomatology, and there are very diverse symptoms for Parkinson's disease these days. So my primary focus of talk is on symptomatology and diagnostic criteria for Parkinson's disease. એવું કહેવાય છે કે those who uses their brain more are at a higher risk of developing Parkinson's disease. So we doctors are at highest risk. So I advise every clinician, every scientist to do work on spinal basis, not a cortical basis. What is Parkinson's disease? It is the second most common neurodegenerative disease. The first one is dementia, and it occurs because of cell loss, apoptosis of the neurons of substantia nigra. That is the region of the brain that controls the movement. Suppose મારે જમણો હાથ ઊંચો કરવો છે તો મારા ડાબી બાજુની બેઝલ ગેંગ્લિયા સર્કિટરીમાંથી ડોપામિન બને, એને કારણે હું હાથ કે પગ હલાવી શકું. જો ડોપામિન ઓછું બને તો મારો હાથ સ્ટીપ થઈ જાય અને એ પાર્કિન્સનમાં કન્વર્ટ થાય, અને જો ડોપામિન વધારે બને તો એ કાં તો ડિસ્ટોનિયા થાય, એબનોર્મલ મૂવમેન્ટ થાય અથવા ડિસ્કાઇનેઝિયા થાય. What are the prevalence? The mean onset of disease is around 60 to 64 years, but we can see younger onset Parkinson's disease, that is below 40 years, but the incidence is around 5 to 10%. Male-female ratio is almost equivalent with slightly higher male preponderance. Over 1 million people in USA and 6.1 million people across the world are suffering from Parkinson's disease according to the data of 2016. So what are the risk factors for Parkinson's disease? Age is the single most common and single most important risk factor. As you advance in the age, there are likely chance of developing Parkinson's disease. In certain cases, juvenile Parkinson's disease can occur, but it is very rare, and juvenile PD, the onset is less than 21 years. Male are more prone, and certain genetic factors like which are identified in Parkinson, mainly SNCA, LRRK2, VPS35 and GBA, all these carries an autosomal dominant inheritance, while PRNK, PINK and PARK7 are autosomal recessive. How to diagnose Parkinson? હું બધાને સલાહ આપીશ કે પાર્કિન્સન એ ડાયગ્નોસ એક જ વસ્તુથી થાય, ક્લિનિકલી અને ક્લિનિકલી. કોઈ એવો બ્લડ રિપોર્ટ, કોઈ MRI, કોઈ સ્પેક્ટ, કોઈ પેટ એ પાર્કિન્સન રોગ ડાયગ્નોસ ના કરી શકે. It is basically a diagnosis by clinical signs and symptoms only. The gold standard in diagnosis, however, is pathology, but it is usually a post-mortem analysis, and there is development of accumulation of alpha-synuclein in substantia nigra. That is the diagnostic hallmark of Parkinson disease. Parkinson is not only pertaining to the motor system. So, Movement Disorder Society has designed a specific criteria, and they have divided the symptomatology of Parkinson in broadly two groups. One is motor and the other is non-motor. What are the motor criteria? Bradykinesia in combination with either resting tremors or rigidity, that is the key characteristic of Parkinson diagnosis criteria. What is bradykinesia? Bradykinesia is a slowness of movement, and Parkinsonian tremors are usually present at rest. એટલું ધ્યાન રાખો કે જે ધ્રુજારી થાય એ બધી પાર્કિન્સનની ના હોય. પાર્કિન્સનની ધ્રુજારી યુઝ્યુઅલી 4 to 6 hertz at rest થાય, and it can affect hands, which is called a pill rolling tremor, also in leg and sometimes in a lips, that is called a rabbit tremors. બધી જ ધ્રુજારી એ પાર્કિન્સોનિયન ના હોય. ક્યારેક ઇસેન્શિયલ ટ્રેમર, ડ્રગ ઇન્ડ્યુસ ટ્રેમર્સ, સાયકોલોજીકલ ટ્રેમર્સ, આ બધા બી એના કોમન કોઝિસ છે. વોટ ઇઝ રિજિડિટી? ઇન્ક્રીઝ રેઝિસ્ટન્ટ ટુ પેસિવ મુવમેન્ટ ઇઝ કોલ્ડ રિજિડિટી. રિજિડિટી થાય અને બ્રેડિકાઇનેઝિયા થાય એટલે સ્લોનેસ ઓફ ગેટ થાય. There are other supportive diagnostic criteria, that is beneficial response to levodopa treatment. પાર્કિન્સનનું પેશન્ટ હોય અને તમે લિયોડોપા કાર્બિડોપા આપો અને જો એ મોર દેન 40% ઇમ્પ્રુવમેન્ટ થાય તો સમજવાનું કે એ પાર્કિન્સન ઇડિયોપેથિક પાર્કિન્સન છે, બીજા કોઈ રેડ ફ્લેગ કે એટિપિકલ પાર્કિન્સન નથી. પાર્કિન્સનનું પેશન્ટને જો લિયોડોપા ઇન્ડ્યુસ ડિસ્કાઇનેઝિયા થાય, એટલે જ્યારે તમે હાઈ ડોઝમાં લિયોડોપા અમુક વર્ષો સુધી આપો એટલે ડોપામાઇનના રિસેપ્ટર્સ બધા સુપર સેચ્યુરેટેડ થાય અને એને કારણે લિયોડોપાને કારણે ડિસ્કાઇનેઝિયા એટલે એક પ્રકારની ડાન્સિંગ મૂવમેન્ટ, કોરિપો મૂવમેન્ટ, આ બધું થાય તો ધીઝ આર સપોર્ટિવ ક્રાઇટેરિયા ફોર ઇડિયોપેથિક પાર્કિન્સન ડિસીઝ. હાઇપોસ્મિયા એન્ડ કાર્ડિયાક સિમ્પેથેટિક ડિનર્વેશન ઇઝ ઓલ્સો કોમન. પાર્કિન્સન ડિસીઝ મેં કહ્યું એમ એકલું મોટર સાઇન્સ અને સિમ્ટમ્સ ના હોય, પણ પાર્કિન્સન ડિસીઝ હેઝ વેરાયટી ઓફ એસોસિએશન વિથ નોન મોટર સિમ્ટમ્સ, દેટ ઇઝ ડિપ્રેશન, apathy, anxiety, psychosis, hallucination, urinary incontinence, REM, sleep behavioral disturbances, excessive daytime somnolence, insomnia, moderate to severe cognitive dysfunction, and orthostatic hypertension and constipation. Even constipation may also be a forerunner of Parkinson disease. આપણે સૌ જાણીએ છીએ કે પાર્કિન્સન એ પ્રોગ્રેસિવ ડિસીઝ છે, એટલે જેમ પ્રોગ્રેશન થાય એમ ધીરે ધીરે વધવાનો છે. નોર્મલી જો પાર્કિન્સનને ટ્રીટ કરવામાં ના આવે તો 7 વર્ષ સુધીમાં મોટાભાગના દર્દીઓ થર્ડ સ્ટેજમાં પહોંચે. એ સ્ટેજનું ક્લાસિફિકેશન એટલે હોર્ન યાહર સ્કેલ ઓફ સિવિયરિટી. સ્ટેજ 1 ઇઝ સ્ટ્રિક્ટલી યુનિલેટરલ, સ્ટેજ 2 ઇઝ બાયલેટરલ. એક બાજુથી શરૂ થાય પાર્કિન્સન ઇડિયોપેથિક યુઝ્યુઅલી એક બાજુથી શરૂ થાય, રાઇટ અથવા તો લેફ્ટ, અને પછી ધીરે ધીરે એ પ્રોગ્રેસ થઈ અને બીજી બાજુ આવે, દેટ ઇઝ સ્ટેજ 2. સ્ટેજ 2માં બે બાજુ ડિસીઝ હોય, બાયલેટરલ ડિસીઝ વિથ પોસ્ચ્યુરલ ઇન્સ્ટેબિલિટી, એટલે ગેઇટ બગડે, બેલેન્સ બગડે, દેટ ઇઝ પોસ્ચ્યુરલ ઇન્સ્ટેબિલિટી. સ્ટેજ 4 ઇઝ સિવિયર ડિસેબિલિટી, પણ પેશન્ટ કેન વોક ઓર સ્ટેન્ડ અનઆસિસ્ટેડ. And stage 5 is usually bedridden or a wheelchair-bound state. Depending upon the symptoms, motor symptoms of Parkinson, it is divided in mainly 3 subtypes. One is tremor predominant. એટલે પેશન્ટને ટ્રેમર્સ હોય, બ્રેડિકાઇનેઝિયા હોય, રિજિડિટી હોય, પણ પ્રિડોમિનન્ટલી ટ્રેમર્સ હોય. ધીઝ આર કોલ્ડ ટ્રેમર પ્રિડોમિનન્ટ પીડી. ધી અધર ઇઝ જ્યાં ટ્રેમર્સ ઓછી હોય અને પોસ્ચ્યુરલ ઇન્સ્ટેબિલિટી અને રિજિડિટી વધારે હોય. This is called postural instability and gait difficulty. PGFD બી કહી શકાય કે એમાં ટ્રેમર્સ ઓછી હોય પણ પોસ્ચ્યુરલ ડિસેબિલિટી અને એને કારણે ગેટ ફ્રીઝિંગ થાય. એટલે સર્ટેન પેશન્ટ ઓફ પાર્કિન્સન may present to you with predominantly gait freezing. And the third group is an intermediate group. Diagnosis કેવી રીતે કરશો? Anyone? Clinical diagnosis. કોઈ MRI, કોઈ PET, કોઈ SPECT પાર્કિન્સન ડિસીઝને ડાયગ્નોઝ ના કરે. હા, but they can be useful for diagnosing secondary Parkinsonism like Creutzfeldt-Jakob, like multiple infarct state, polytrauma, multiple head injuries, punch બોક્સિંગ બોક્સર્સને લાંબા ગાળે પાર્કિન્સન થઈ શકે, ફૂટબોલરને વારે ઘડીએ જે હેડર કરતા હોય એ લોકોને પાર્કિન્સન, દેટ ઇઝ કોલ્ડ પોસ્ટ ટ્રોમેટિક પાર્કિન્સન. આ બધા ડાયગ્નોસિસ તમને માટે એના માટે MRI હેલ્પ કરી શકે. સો મેઇનલી સ્ટ્રક્ચરલ MRI બ્રેન, રેડિયો ટ્રેસર ઇમેજિંગ SPECT or PET, and alpha-synuclein tissue markers are also available. But unfortunately, tissue markers are more specific and sensitive, but they are not commercially available. It is only a research purpose. મેં કહ્યું એમ મોટા ભાગના પાર્કિન્સન ડિસીઝ પેશન્ટમાં MRI નોર્મલ હોય, પણ ઘણી વખત પાર્કિન્સનમાં નોર્મલી આ સબસ્ટન્સ નાયગ્રા છે એનો તમે MRIમાં એપિયરન્સ જુઓ તો પક્ષીની જે ટેઇલ હોય એવો હોય, એટલે વચ્ચે ખાંચો હોય, દેટ ઇઝ કોલ્ડ સ્વોલો ટેલ. જ્યારે પાર્કિન્સન થાય ત્યારે એ સ્વોલો ટેલ એપિયરન્સ જતો રહ્યો હોય. સો લોસ ઓફ સ્વોલો ટેલ એપિયરન્સ ઇઝ અ characteristic and maybe an helpful in diagnosis of idiopathic Parkinson disease. MRI can be useful for diagnosing vascular Parkinson disease, small vessel disease, classical bitemporal involvement in CADASIL, and multi-infarct state where there is predominantly white matter hyperintensities. MRI is very useful in diagnosing atypical Parkinsonian syndrome, that is progressive supranuclear palsy, multisystem atrophy, diffuse Lewy body disease. આ બધા ડિસીઝમાં લિયોડોપા આપો તો પણ રિસ્પોન્સ જોઈએ એવો મળે નહીં, એટલે પેશન્ટ પાર્કિન્સન જેવા લક્ષણ લાગતા હોય પણ બધા એટિપિકલ પાર્કિન્સન હોય. આ કેસીસમાં PET, MRI એ બધું હેલ્પફુલ થઈ શકે, જેને કારણે તમે ક્લિનિકલી અને રેડિયોલોજીકલી ડાયગ્નોસિસને સપોર્ટ કરી શકો. PSPમાં ક્લાસિકલ હમિંગબર્ડ એપિયરન્સ આવે, ધીસ ઇઝ હમિંગબર્ડ, એન્ડ MRI શોઝ હમિંગબર્ડ એપિયરન્સ ડ્યુ ટુ એટ્રોફી ઓફ ધી મિડ બ્રેન. મિડ બ્રેનની એટ્રોફી થાય એટલે થર્ડ વેન્ટ્રિકલ એની એપિયરન્સ હમિંગબર્ડની બીક જેવી થઈ જાય. સો ધીસ ઇઝ અ હમિંગબર્ડ સાઇન ઇન PSP. Hot cross bun sign in multisystem atrophy. In multisystem atrophy, you can notice atrophy of the pons, atrophy of the cerebellum, and prominence of vertical and horizontal fibers of pons. So this prominence cause hot cross bun sign. However, hot cross bun sign is not the diagnostic hallmark in multisystem atrophy. It can also occur in spinocerebellar ataxia. How to manage? Mainly ફાર્મેકોથેરાપી તો જરૂરી છે જ, પણ એની જોડે એક્સરસાઇઝ, ફિઝિયોથેરાપી અને સાયકલિંગ ઇઝ વેરી હેલ્પફુલ ઇન પાર્કિન્સન ડિસીઝ. હું દરેક પેશન્ટને કહું કે જો તમે એકલી દવાઓ કરશો ને ફિઝિયોથેરાપી નહીં કરો તો 100 ડબ્બા મૂકું, પણ જ્યાં સુધી ગાડીને એન્જિન ના લાગે ત્યાં સુધી ગાડી આગળ જશે નહીં. એટલે પાર્કિન્સનમાં ફિઝિયોથેરાપીનો રોલ બહુ જ ઇમ્પોર્ટન્ટ છે. અને નેધરલેન્ડના એક સર્વે મુજબ 30 minutes cycling per day can reduce his tremors to more than 40 to 50%. એટલે only cycling can reduce the tremors in Parkinson disease. Apart from pharmacotherapy and physical therapy, in certain selected cases, surgical therapy in form of deep brain stimulation of either substantia STN or GPI, it can be useful in management of Parkinson. So what are the options for pharmacotherapy? The main and most important is levodopa and carbidopa. It is the main agent and it causes greatest significant symptomatic relief. However, there are certain issues with therapy of levodopa and carbidopa. Early stage માં જ્યારે તમે ચાલુ કરો ત્યારે હંમેશા એક ડિક્ટમ છે કે સ્ટાર્ટ લો ગો સ્લો. જો તમે જલ્દીથી ટાઇટ્રેટ અપવર્ડ્સ કરો તો ઇમિડિયેટ સાઇડ ઇફેક્ટ્સમાં પોસ્ચ્યુરલ હાઇપોટેન્શન, નોઝિયા અને સિવિયર વોમિટિંગ થઈ શકે. એન્ડ as the disease progresses, you have to give levodopa carbidopa lifelong. So after 7 to 10 years, patient may develop levodopa-induced dyskinesia. That is mainly peak dose. જ્યારે ડોઝ મેક્સિમમ લેવલ પર હોય, પ્લાઝમા લેવલ કોન્સન્ટ્રેશન લેવોડોપાનું મેક્સિમમ હોય ત્યારે ડિસ્કાઇનેઝિયા થાય. ધી અધર વેરાયટી ઇઝ એન્ડ ઓફ ડોઝ, દેટ ઇઝ લોએસ્ટ કોન્સન્ટ્રેશન હોય ત્યારે પણ ડિસ્કાઇનેઝિયા થઈ શકે અને ડ્યુઅલ ડિસ્કાઇનેઝિયા. અને ઘણી વખત એવું થાય કે તમે લિયોડોપા આપો પણ એની અસર જ ના થાય, પેશન્ટને જરાય અસર જ ના થાય. દેટ ઇઝ કોલ્ડ સડન ઓફ ફિનોમિના. ડોપામિન એગોનિસ્ટ, these are useful drug in managing some of the symptoms of Parkinson disease. These are mainly D2 type subtype dopamine receptor agonist. First generation is not widely useful. Second generation may be useful mainly in second generation. Ropinirole and pramipexole are available. Rotigotine is not available. But there are major issues with dopamine agonists are side effect. It can cause hypersomnolence, hypersexuality, compulsive gambling. એટલે યુએસએમાં તો ઘણી વખત કમ્પલ્સિવ ગેમ્બલિંગ, આપણે ત્યાં તો ગેમ્બલિંગ લીગલ નથી, યુએસએમાં લીગલ છે, પણ કમ્પલ્સિવ ગેમ્બલિંગને લીધે રોપિનિરોલ કે પ્રેમિપેક્સોલ બંધ કરવી પડે. Emantadine is a very useful drug. It's an NMDA receptor antagonist. It has mild anti-Parkinsonian effect, but it is very useful in levodopa-induced dyskinesia. MAO-B inhibitor, salicylic and razagiline and safinamide. પહેલાં એવું કહેવાતું હતું કે આ બધાના ન્યુરોપ્રોટેક્ટિવ એક્શન છે અને એ પાર્કિન્સન ડિસીઝને સ્લો કરે છે, પણ નવા સ્ટડીઝ પ્રમાણે એવી કોઈ મેજર ઇફેક્ટ આવતી નથી. It can be useful mainly in motor fluctuation, particularly in early stage of Parkinson. Anticholinergic, જે બધાની ફેવરિટ, કોઈ પણ જીપી કે ફિઝિશિયન ધ્રુજારી થાય એટલે પેસિટેન આપવાની. આમાં મેઇનલી બે દવા છે, ટ્રાયએક્ઝિફેનિડીન અને પ્રોસાયક્લિડિન. પણ there is very high level of side effect, particularly in elderly patient, કેમ કે પાર્કિન્સન યુઝ્યુઅલી 60 ને 64 પછી થાય. એ વખતે જો એન્ટીકોલિનર્જિક્સ આપીએ તો ઇટ કેન કોઝ સિવિયર યુરિનરી રિટેન્શન, સિવિયર કન્ફ્યુઝન and sometimes severe hallucination, and in such a scenario it is difficult to manage. એટલે 60 પછી પાર્કિન્સનવાળા પેશન્ટમાં પેસિટેન આપતા પહેલાં 10 વખત વિચારવું પડે. What are the treatment options for advanced stage PD? COMT inhibitors mainly entacapone, opicapone અને tolcapone. Apomorphine ઇન્ડિયામાં અવેલેબલ નથી. DBS, it's a better option, surgical option, particularly in selected cases, and levodopa carbidopa gel. આ પણ ઇન્ડિયામાં અવેલેબલ નથી. જેટલા તમે મોટર સિમ્ટમ્સને ટ્રીટ કરો, જેમ કે રિજિડિટી, ગેઇટ, બેલેન્સ, એટલી જ રીતે તમારે નોન મોટર સિમ્ટમ્સને પણ ટ્રીટ કરવા પડે, કેમ કે ઇટ કેન અફેક્ટ યોર એક્ટિવિટી ઓફ ડેઇલી લિવિંગ. ડિપ્રેશન હોય તો પ્રોપર એન્ટીડિપ્રેસન્ટ આપવાની, સાયકોસિસ હોય તો ક્વિટિયાપિન અને ક્લોઝાપિન એન્ટીસાયકોટિક તરીકે આપી શકાય. યુરિનરી ઇન્કોન્ટિનન્સ હોય તો સોલિફેનાસિન અને ઓર્થોસ્ટેટિક હાઇપરટેન્શન માટે મિડોડ્રિન. વોટ આર ધ રેડ ફ્લેગ્સ? ધીઝ રેડ ફ્લેગ્સ આર વેરી ઇમ્પોર્ટન્ટ. રેડ ફ્લેગ્સ મેઇનલી બે વસ્તુ માટે જરૂરી છે, કે સેકન્ડરી પાર્કિન્સોનિઝમ છે કે નહીં એ જોવાનું, અને પાર્કિન્સન જેવા લાગતા પણ ભળતા રોગો છે કે એટિપિકલ પાર્કિન્સન, આ બે વસ્તુ જોવાનું. તો એના માટે ક્લિનિકલ રેડ ફ્લેગ્સ છે એ બહુ જ જરૂરી છે, કેમ કે સેકન્ડરી પાર્કિન્સોનિઝમ અને એટિપિકલ પાર્કિન્સોનિઝમ એ રૂટીન પાર્કિન્સનની દવાઓથી 20 to 30% જ રિસ્પોન્ડ કરે, એ સિવાય રિસ્પોન્સ ના આવે. અને ઘણી વખત ખોટા કેસમાં DBS થઈ જતું હોય અને જે જોઈએ એ રિઝલ્ટ ન મળે. તો વોટ આર ધીસ ક્લિનિકલ રેડ ફ્લેગ્સ? Rapid progression to wheelchair-bound state in 5 years of disease onset. Patient could be having progressive supranuclear palsy or multisystem atrophy. No motor progression for 5 years. Patient ને ખાલી ધ્રુજારી હોય 5 વર્ષ સુધી, કોઈ જાતનું મોટર પ્રોગ્રેશન ના હોય, કોઈ રિજિડિટી ના હોય, તો યુઝ્યુઅલી these are subtypes of essential tremors. Early bulbar or pseudobulbar dysfunction. Patient could be having progressive supranuclear palsy or PSP. બલ્બર ડિસ્ફંક્શન એટલે આંખના મૂવમેન્ટ બંધ થઈ જાય, ખોરાક ગળવામાં તકલીફ થઈ શકે, બોલવામાં સ્પાસ્ટિક સ્પીચ આવે. ધીઝ આર ઓલ કોલ્ડ બલ્બર સાઇન્સ. સ્ટ્રાઇડર ઇઝ ધ ડાયગ્નોસ્ટિક હોલમાર્ક્સ ઓફ મલ્ટીસિસ્ટમ એટ્રોફી. Recurrent falls within 3 years of onset of illness. પાર્કિન્સનનો દર્દી આવે અને 2 થી 3 વર્ષમાં જો પડવાનું ચાલુ કરે તો સમજવાનું કે આ ઇડિયોપેથિક પાર્કિન્સન નથી. યુ આર ડીલિંગ વિથ એટિપિકલ પાર્કિન્સન અને મેઇનલી PSP. અને આ બધા જ એટિપિકલ પાર્કિન્સન ફિઝિયોથેરાપી કે ફાર્મેકોથેરાપીથી પ્રોપર રિસ્પોન્ડ ના કરે. દેર ઇઝ ઓનલી 30 to 50% રિસ્પોન્ડ રેટ ઇવન આફ્ટર maximum pharmacotherapy and maximum physiotherapy. Severe autonomic failure within 5 years of onset of illness, that is multisystem atrophy. Enterocolis, gardan agar thai jai, that is called enterocolis. In 10 years, patient may be having progressive supranuclear palsy. Unexplained pyramidal sign like deep tendon reflexes are brisk, Babinski sign is positive, so you are dealing with either PSP or multisystem atrophy. Note, in elderly patient, Parkinsonian patient may have associated cervical spondylosis. In that case, you can have a pyramidal sign. So, unexplained pyramidal signs, you have to suspect PSP or MSA. Severe fluctuation and form visual hallucinations. પાર્કિન્સનનો દર્દી ઘડીકમાં સારો હોય ને ઘડીકમાં એકદમ ખરાબ થઈ જાય. અને હેલ્યુસિનેશન્સ અને ફોર્મ વિઝ્યુઅલ હેલ્યુસિનેશન્સ એટલે કે સાંજ પડે ટિપિકલ સન ડાઉનિંગ આવે અને એને જાત જાતની ઇમેજો દેખાય. ધીઝ આર કોલ્ડ ફોર્મ વિઝ્યુઅલ હેલ્યુસિનેશન. ઇન સચ કેસ you may be dealing with diffuse Lewy body disease. So what is the concluding remark? It is a common neurodegenerative disease with very diverse motor apart from non-motor symptoms. Symptomatic treatment is available. You must treat non-motor symptoms because it can affect your activity of daily living. Surgical option in form of DBS is available, and in future gene therapy or the alpha-synuclein target therapy may also be available. Thank you. Any questions?
Hello. Good morning, sir.
જો ટાઈમસર ટ્રીટમેન્ટ થાય તો યુ કેન રિડ્યુસ ધ પેસ ઓફ ધ ડિસીઝ, બટ યુ કેનોટ હોલ્ટ. કોઈ ન્યુરોપ્રોટેક્ટિવ એજન્ટ્સ એવું કોઈ છે નહીં કે જે ડિસીઝને હોલ્ટ કરે, પણ ઇન પ્રોપરલી ટ્રીટેડ પેશન્ટ યુ કેન ઇન્ક્રીઝિસ ધ ડ્યુરેશન ફ્રોમ going into stage 1 to stage 2. Yes.
Hello. Good morning, sir. Sir, as in surgical option, there is a DBS over there. So, what can be the criteria for the Parkinson person for going for DBS or not?
DBS is usually a surgical option for first and foremost is idiopathic Parkinson. If patient is having secondary Parkinsonism or an atypical Parkinson, then DBS is contraindicated. And DBS is mainly useful for pharmacodynamic and pharmacokinetic complication of levodopa. એટલે પેશન્ટને ડિસ્કાઇનેઝિયા ટ્રબલસમ રહેતો હોય તો DBS યુઝ કરી શકાય. પણ DBS ડઝન્ટ ઇમ્પ્રૂવ સ્પીચ. એટલે જો સ્પીચ ડિફિકલ્ટી ટાર્ગેટ હોય તો DBSથી ફાયદો ના થઈ શકે. બટ ઇન જનરલ idiopathic Parkinson disease that is responsive to levodopa carbidopa combination and having severe fluctuation after levodopa and carbidopa treatment in form of severe troublesome dyskinesia with age around 60 to 70 years. These are the significant number of patients that can benefit with DBS therapy.
And sir, is there any adverse effect of DBS?
Yeah, it's a surgical procedure. જ્યારે લીડ પ્લેસમેન્ટ કરતા હોય ત્યારે ઇટ કેન કોઝ બ્લીડિંગ. સમટાઇમ્સ infection is very common, and DBS doesn't improve gait, and sometimes it can reduces the effectiveness of levodopa and carbidopa, need of levodopa and carbidopa therapy. But like any surgical, it carries a risk.
And sir, after DBS, is there any pharmacological reduction like a reduction of in levodopa or carbidopa?
Yeah, that's true. Depending upon the need for stimulation and response to the patient, you can definitely reduce the dosage requirement of levodopa and carbidopa after DBS.
Okay, thank you, sir.
Sir, after levodopa or carbidopa treatment, sometimes or after sometimes the DBS is continued. So how we can give a DBS in criteria like मतलब કે DBSમાં એજ એક DBS આપ્યું તો થોડા ટાઈમ પછી એની ઇફેક્ટિવનેસ રિડ્યુસ થઈ જાય છે, તો એના વચ્ચે એ જ ડિફરન્સ કેટલો હોવો જોઈએ કે કેટલા ટાઈમ પછી આપણે DBS આપી શકીએ?
નોર્મલી જો પાર્કિન્સનનો પેશન્ટ હોય અને લેવોડોપા કાર્બિડોપાના માઇલ્ડ ટુ મોડરેટ ડોઝ જેમ કે 125 TDS કે 125 5 times a day ઉપર સ્ટેબલ હોય, એને એક્ટિવિટી ઓફ ડેઇલી લિવિંગ ઓલમોસ્ટ ઇન્ડિપેન્ડન્ટ હોય, કોઈ જાતના ડિસ્કાઇનેઝિયા ના થતા હોય, તો આઈ વુડ નોટ રિકમેન્ડ DBS ફોર દેટ પેશન્ટ. જો ડોઝ રિક્વાયરમેન્ટ જેમ કે લિયોડોપા કાર્બિડોપા 125 ડેઇલી 12 to 13 ટેબ્લેટ્સની હોય, he is facing severe troublesome dyskinesia or dystonia that is affecting his daily activity of daily living and that cannot be managed by dose titration. These are the candidate whom I can refer for a DBS.
Okay, sir. Thank
There
you.
is no duration of Parkinson that is a contraindication for DBS. Patient can go directly to DBS, but it's a recent technique and I think we should wait for further 10 to 15 years for as a primary treatment for Parkinson disease. Thank you.
Thank you very much, Amit sir. Our next speaker is Dr. Gopal Raval. Sir is a highly accomplished and widely respected pulmonologist who is also an expert in critical care and sleep disorders. And sir also teaches DNB students in critical care medicine. Dr. Gopal Raval, sir.
Thank you, Avron Hospital, Jagrut sir, Jigar bhai, and particularly thanks to Dr. Jainam and Dr. Forum for initiating such a wonderful CME. And actually, first time I'm speaking in front of the physiotherapist, and my topic is role of physiotherapist in lung disease. So whatever I practice in last 18-20 years and how I utilize physiotherapist in my practice, that experience what are the conditions in pulmonary medicine that I can treat with the help of physiotherapist. And I believe that in a teamwork. So as the team mnemonic itself says that together everyone achieves more. So what I achieved in last 18 to 20 years with the help of my physiotherapy colleague. So I think you all know that rehabilitation part is very well important in the part of all medical conditions. When I start my practice, there was a cardiac rehabilitations. Then that was way back in 1985, one of our senior cardiologists who started. Then I believe in the pulmonary rehabilitations, and nowadays each and every specialty that they involve the rehabilitation program. So that respiratory physiotherapist, I think you have a MPT in cardiorespiratory also, ortho, neuro. So what I believe that it's a core specialty within the physiotherapy professions, and it occupies key role in the management of and treatment of the respiratory disease. So most of 80 to 90% of respiratory disease we needs physiotherapist help, and most of respiratory condition we need pharmacological and non-pharmacological treatments. So our aim is to unclog the patient's airway and help them to return back to normal physical activity, and the patient can do some sort of exertion though he has underlying respiratory disease. And this respiratory physiotherapist employs many diverse intervention. They do pulmonary rehabilitation, early mobilizations, airway clearance. That is most important thing in our disease like airway disease, COPD, asthma, interstitial lung disease, early mobilization which helps to avoid the pulmonary embolism also. So it is a very disaster disease, but if the experienced physiotherapists who start early mobilization, and he can able to prevent the pulmonary embolism, and airway clearance technique, particularly in bronchiectasis, cystic fibrosis, COPD patient, that is the most important thing, and they have a beneficial effects on the symptoms associated with the respiratory disease. The beneficial effects are demonstrated, most important thing, in the improve the functional ability of the patients and reduce the intensive care though and hospital stay, because we know that whatever amount of patients spend time in the intensive care unit or in the hospital, then there is a chance of getting secondary infection. Patient may land up with the hospital acquired infection or ventilator associated infection. So with good physiotherapy care, we can prevent that, we can reduce the hospital stay, we can reduce the ICU stay also, and important thing, vitamin M. So associated healthcare quality, that's the most important thing. It's a needed part of that. So and that this physiotherapy can work in the intensive care unit, hospital. They can do a primary care settings also. They can start their own rehabilitation care also. Okay. So chest physiotherapy, that includes the management of patient with excessive airway secretions, oxygens. They help to improve the oxygenation also, improving the lung volume capacity also, musculoskeletal, because most of respiratory conditions are not a disease, it's a syndrome. If you know that COPD, it's a syndrome. Sleep apnea, it's a syndrome. So, and interstitial lung disease is also syndrome, one kind of syndrome. So in that syndromes, physiotherapy helps to preserving the musculoskeletal function, because whatever I've seen in my pulmonary patients, after some times they lose their capacity, their muscles goes down and they won't able to walk and they become breathless. So that conditions we can improve with the help of the physiotherapist, and advice, that's providing the good advice and education to the patients and patient caretaker, because we need to treat the patient also, need to treat the patient's relative also, okay, nowadays. And so these respiratory physiotherapists have an essential role in early mobilization, exercising, and muscle retraining exercise. So this is a little bit introduction about what the chest physiotherapist can do. So these are the common pulmonary respiratory problems. In that, we know that I need a physiotherapist help. Pneumonia, airway disorder like asthma, bronchitis, cystic fibrosis, bronchiectasis, parenchymal lung disease. There is a huge list of interstitial lung disease, so many interstitial lung disease like idiopathic pulmonary fibrosis, hypersensitivity, sarcoidosis, all kind of interstitial lung disease. In that, we need a pharmacotherapy plus a good physiotherapy that can improve the patient's capacity, improve the oxygenation. Then my loved topic is the sleep disorders. So in that, not only the CPAP works, but the good physiotherapy care, good rehabilitative care also helps that. Then important thing is a thoracic cage deformity. Either it's a congenital or after certain disease patients develop thoracic cage abnormality. Pleural disease also, that residual pleural thickening, and that because of the empyema. In that, the good physiotherapy can help for the patient better management, and also in the lung malignancy, how the physiotherapy can help in the malignancy. So that is also important thing. In malignancy, that end of life care and how to manage the palliative care with the help of physiotherapists, that is the most important thing. So here, these are little bit risk factor for the lung disease, particularly our airway disease, that we all know that urbanizations, lot of concrete jungles we have seen in our cities, and we are going towards the metro cities. So that is also that pollutions. India is affected by two P's, pollutions and populations. A lot of these two P's disturbing India's, that leads to third P, poverty. Okay, so that we have to take care. Then unhealthy diet. We all know that we are fond of that unhealthy diet, I don't want to discuss anything more, and then physical inactivity, because in one slide I prepared that initially the TV was very big TV, now very slim TV came, and initial days the patients are very thin and lean, now the patients are this big. So there is the diversion of these two things. Then the status of using tobacco, then that's hookah and everything. Passive smoking is also affecting. Then indoor air pollutions, because I will discuss that COPD is now more common in the female also. That is because of biomass fume exposure. Then outdoor pollutions, that is also important things. This risk factor for the asthma, that allergic reactions, certain occupational lung disease. Now, these are the manifestation of the pulmonary disease. What that sneezing, that is a reflex response to the irritation of the upper respiratory tract, coughing, sputum productions, and physiotherapists should know that which color of the sputums, and that is likely due to what. That is important thing. Then breathing pattern, that is the most important thing. Rather than to doctor picked up the things like consultant physician, it is duty of the physiotherapist that he can pick up and he can say, sir, this is a patient having labored breathing, patient may need some positive pressure supports also, patient having acidotic breathing. So that notification of the breathing, either the patient having wheezing, stridors, that things can be able to judge by the physiotherapist. Then the dyspnea, that is the whether the patient having orthopnea, tachypnea, what kind of breathlessness patient. Then the cyanosis also. Once you go for to give the physiotherapist that patient, then patient is tachypnic, patient having cyanosis, then you have to pick up. That is a what the previous speaker that Amit Bhai, so that is a red flag things. You have to early picked up and properly should be treated. Okay. This is a little bit about, I am not going to detail to tell the what's asthma and the things, just few slides for the asthma. We all know that it's a chronic disease of the airway and it's episodic disease. So that's why the patients are not keen to take the inhalers, because sometimes it subsides its own. But its presentation, patient may have a wheezing, breathlessness, chest tightness, and sometimes nighttime symptoms also. And these are the type of substance which gives which are responsible to trigger the asthma. And that last is a food. And asthma is also known as a which restaurant syndrome? Anybody knows? Asthma is known as a Chinese restaurant syndrome. So the Chinese sauce, what you are taking, that monosodium glutamate, Ajinomoto, and if you take that, and if the person having the allergy, he might get having the acute exacerbation of asthma. And these are the other factors, because nowadays I have a few patients, they tell me that I cannot live without my dog, it's my baby, okay? So that kind of was, so then you have to ship that patient with their baby to the hospital, okay? So that to know the triggers is a very most important thing, and the prevention. So asthma is a two type, pharmacological and non-pharmacological treatments. Okay. Then COPD is a common clinical problem and it's a syndrome. COPD patient, they should refer to the physiotherapist from the first day, because the patient need a good rehabilitative care and it prevents the progression of the disease. It cannot stop the disease, but it can prevent the progressions of the disease. So it includes bronchitis and emphysema. The disease is progress over the period of time and leads to respiratory disability and the death. So to delay that disability and death, we need a good, my physiotherapist should guide him how to take the breathe and with the pharmacological therapy, okay? These are the risk factor for the COPD: exposure of the tobacco smoke, active or passives, then poor nutrition and other comorbidities. This is bronchiectasis. You all know that's one of the cause for the bronchoria. When the patients have excessive sputum, foul smelling sputum, then this patient may have a bronchiectasis. We tell them, tamara lungs માં ચાંદી પડી ગઈ છે. એટલે recently I had a patient કે એણે શું કર્યું કે મેં આવું કીધું કે તમારા લંગ્સમાં સિસ્ટ થઈ ગયા છે, એટલે એણે ગૂગલ ટ્રાન્સલેટમાં નાખી દીધું કે લંગ્સ ઇન સિસ્ટ, એટલે ગૂગલે કીધું ફેફસામાં કાણું. ઓકે, સો એ રીતના ઇમિડિયેટલી પેશન્ટ કમ્સ ટુ મી કે સાહેબ મારા ફેફસામાં કાણું પડી ગયું છે, હવે કંઈક કરો. But then I explain that what to do. He needs a good physiotherapy, breathing exercise, postural drainage. That is the most important things. Same way cystic fibrosis, that is an inherited disease, and they have a very thick secretion, sticky sputum, and it damages the most body organs, particularly chest and the digestive systems. So in that patients also a good rehabilitative care is needed. So goal of airway disorder is the disease prevention is the ultimate goal of the airway disease. Then once airway disorder has been diagnosed, then effective management should be aimed like relieve the symptoms, prevent the disease progressions, improve the exercise tolerance, improve health status of the patients, prevent and treat the complication, prevent and treat the exacerbation, because each exacerbation that leads to 10% decrease in patient's lung capacity. Each exacerbation decrease 10% in the patient's capacity. So you have to prevent the exacerbations, reduce mortality, and prevent or minimize side effect of the treatment. That also you have to explain to the patients. Then the pulmonary hypertension, how the physiotherapy can help. You know that pulmonary hypertension is the blood pressure of the lungs. That is also, it is also progressive condition, and it affects the arteries and the lungs and right side of that heart failure. Symptoms are same, that shortness of breath, dizziness, chest pressures and symptoms. The condition worsen over a period of time. So with good medications and pulmonary rehabilitation with oxygen support, we can helps to lessen the patient's symptoms and improve the health related quality of the life of the patients. Okay. Then the pulmonary embolism, I explained that it's a very disaster disease. Patients, you can have any kind of patients, surgical patients or medical patients who are bedbound. You need to prevent the DVT and followed by the pulmonary embolism. And in that also the exercise, limb exercise, active, passive, that helps to prevent the conditions. Thoracic cage abnormality, I explained that is the structural abnormality of the chest, can be range from mild to moderate, severe. Particularly these kind of patients, prior the surgery, they needs a good breathing exercise. Recently I had a patient who has a kyphosis and operated for the hiatus hernia. Patient prior the surgery, he was absolutely fine, but after the surgery, that patient was rapidly decompensated because of it was just touching on the baseline. So such patients need, prior the surgery, they need a good breathing exercise, physiotherapy to prepare the patients to overcome the surgical post-op complications. Okay. Pneumonia and malignancy. Pneumonia, particularly in that condition, breathing exercise to prevent the recurrent pneumonia. In that, how physiotherapy can help, that he can help to advise for a good diet, vaccinations, good particularly breathing exercise, and like bronchiectasis, COPD patients, postural drainage, percussion therapy, airway clearance, that can help to prevent the recurrent pneumonia. And in the malignancy also that helps to improve the quality of life and with a good palliative care. Okay. Sleep disorders, that's a lifestyle disorders. Okay. So everyone, even I can know, even I was noticed somewhere here also, because everyone snores. Okay, so these sleep disorders are also helpful, and in these physiotherapists can help. So there are 88 sleep disorders. Okay, there are 88 sleep disorders, and OSA one of them. So it's described, it's a repetitive episode that of complete or partial upper airway obstruction during the sleep, and that leads to night awakening, hypoxemia, and lots of side effects with that. And one of the cause is the obesity for that. No doubt in India we have a lot of this facial structural also that is responsible, like hypognathia and micrognathia is also responsible for that. And symptoms are snoring, excessive daytime sleepiness, witness apnea, choking, nocturnal awakening, nocturia, unrefreshing sleep. And this sleep disorder, beauty of this disorder is this patient can present to anybody. Like nocturia, he can present to the urologist also. If a patient may have an accident, then he can present to the orthopedic surgeons. Headache, he can present to the neurologist. So this kind of patient present to anybody, but they have to picked up and diagnose the disease. That can be diagnosed by the proper overnight polysomnography, and for that prior patient should be evaluated in proper way. Okay, so now what happens if this kind of patients are not treated? This is the chunk. Patient can have a myocardial infarctions, hypertension, tachycardia, bradycardia symptoms, stroke, hemorrhage. The middle one, that's for our medical students, that they can have the ability to pick up their reflex. It's reduced. Memory, interpretation is also reduced. So that is most important thing. Accident, sugar, and last in the US, this was also most common, divorce, because of the heavily snoring. So that is also important. Okay. Then therapies, pulmonary rehabilitations, weight loss, nocturnal positioning, avoidance of alcohol and sedatives, sleep deprivation, one of the cause for the sleep disorder, sleep deprivation, because every hospital writes that 24/7. Who will run 24/7? So that is most important thing, and you have to prevent the sleep deprivation also, and sleep hygiene. So that we have to fix bedtime and fix awakening time, that things you have to keep in the mind. Reduce the body weight, that is the treatment for that. And reduction in body weight, then can patient sometimes may not need to CPAP usage. Then parenchymal lung disease, that's what we call is a ILD. It's a lung scarring, and if scarring occurs, and it is irreversible, and the patient may have a dry cough, shortness of breath. Sometimes the patient's feeling that, sir, હું થોડું ચાલું છું ને થાક લાગે, બીજું કંઈ જ નથી, ખાંસી કે એવું કંઈ જ નહીં, શ્વાસ બી નહીં, પણ હું ચાલું ને તો થાક લાગે. That થાક is because of hypoxemia. Hypoxemia can lead to muscle fatigue. So that things you have to pick up. Any of your patients, any patient, cardiac, neuro, that patients complaining like that, and if you notice nowadays, because of grace to COVID, we all know that pulse oximeters. So that if we find that oxygen desaturation occurs after walking certain distance, then this patient may have a parenchymal lung disease. So ILD is not a lung disease, as I meant, it's a syndrome, and the consequence of ILD is peripheral muscle dysfunctions, respiratory muscle dysfunction, nutritional abnormalities, cardiac impairment, skeletal disease, sensory deficit, and psychological, because most of lung disease, they have a psychological, because they are chronic disease. Okay, so pulmonary na patients thoda screw over a period of time ઢીલા થાય, એના ડૉક્ટરના બી થાય. Okay, so interstitial lung disease, this is the chart. It's a very good chart, how it's dyspnea and everything that leads to exercise intolerance. And mechanism for this morbidity is deconditioning, malnutrition, effect of hypoxemia, steroid myopathy, hyperinflations, diaphragmatic fatigues, frequent hospitalizations, effect of various medication, and psychological dysfunction. So overcome this all basket of lung disease, a beautiful pulmonary rehabilitation helps, and it is a comprehensive intervention based on through the patient assessment. That is the most important thing. Assessment followed by the patient's tailored therapy that includes exercise training, educations, behavioral change designed to improve the patient's physical and psychological disorders. And physiotherapists play an integral part in management by giving techniques aimed to reduce the work of breathing and improve the disability. These are that patients, and these are the component of the pulmonary rehab, like physicians, physiotherapists, psychologists, dietitians. That team should work together and improve the patient's quality. This is a picture of the pulmonary rehabilitation. I think rather than me, you are knowing more than me. So this kind of the management should be done. Component of the pulmonary rehab. These are the what I understand the benefits of the pulmonary rehab. That's secondary morbidities that are treatable if recognized. Pulmonary rehab program includes the prevention, early recognition, and treatment morbidities, and increase the independency, because most of pulmonary patients are dependent patients, so they now become independent and improve the quality of life, and fewer hospitalization and shorter hospitalization time, improve the exercise capacity, improve health related quality of life, reduce the intensity of the breathlessness, hospitalization, increase survival, improve psychological well-beingness. These are some component of the pulmonary rehab. 6-minute walk test generally we use in pulmonary hypertension patients and interstitial lung disease. By that we can explain the prognosis of the patients. I'm not going in detail. These are the exercise strategy. Either it could be a home-based rehabilitations, OPD-based. I will not bore you more than 5 minutes. Sorry. Okay. Tally rehabilitation. This is a new concept started, I think, either some of you are using. One of physiotherapists, Hiral, is sitting here. She is treating my patient on a telemedicine base. So that's the important thing that improves the patient's quality of life, reduce the hospitalization. That's the most important. So aims of chest physiotherapy to facilitate the removal or retain or profuse airway secretion, optimize lung compliance, ventilation perfusion ratio, and improve the gas exchange, decrease the work of breathing, improve exercise tolerance, prevent secondary complications. I will not going in detail because after me that Dr. Jainam will explain you what's the pulmonary. He has some few videos also. So when to advise for the chest physiotherapy, that I should not advise you, tell you, you should know that excessive sputum production, effectiveness of the curve, then change in the vital signs, and this is the list of airway clearance technique, education of the patient's diet and nutrition therapy. How you know that your therapy is effective? Change in sputum production, breath sound improved, patient's vital change, X-ray also improve. These are certain contraindication of physiotherapy I will not discuss. And be aware of this complication, because a physiotherapist should be trained in the BLS and ACLS training. BLS and ACL, they should know, because anything can happen, particularly the chest physiotherapy. Any one of you come across with that while performing the exercise, your patient might have arrest, so you have to be very careful. These are the complications of chest physiotherapy, likely. And these are the myth busters, that older people will not get benefited with exercise. Poor lung function means poor exercise tolerance and poor results. Smoker will not get benefited. Too much comorbidity will lead to a failure. The last things I will tell, the sickness is the poverty. If the person is in the ICU spending this much amount, after paying the hospital bill, this is like this, okay? So thank you very much. That is a health is wealth, and healthy lung for a wealthy life. Thank you so much. Any question? I think I am the barrier. I should not be barrier between lunch and you people. જો કોઈ ક્વેશ્ચન ના હોય તો કાં તો મારું લેક્ચર બહુ સારું હોય કાં તો એકદમ ખરાબ હોય. થેન્ક યુ.
Thank you so much, Gopal sir. Indeed, it was a wonderful session. And if anyone was caught sleeping, his photo is going to be there on Gopal sir's next presentation. Right. Okay, 15 more minutes, guys. You have been so patient. I really appreciate your patience. Right. I know bhukya thaya chiye, but we only got one more session. He is one of you. His name is Dr. Jainam Shah. He is a practicing physiotherapist. He is an MPT in cardiopulmonary. Right. Thank you so much, guys. Please welcome Dr. Jainam Shah.
Good afternoon. As Sir very well explained about what is a PR, pulmonary rehabilitation, I will not go in the definition of the PR. As you know, it is a comprehensive treatment which includes the psychological support, exercise training, behavioral training, as well as dietitian, as well as main important is a pulmonologist. So it is a comprehensive treatment for all the supports. After that, we can start the PR, and our main integral role of the PR as a physiotherapist is a exercise training, and they improve the breathing pattern, reduce the work of breathing, as you know. How to select the patient that એ PR કરી શકશે કે નહીં, એ પલ્મનરી રિહેબિલિટેશનમાં એનરોલ થઈ શકશે કે નહીં, એ ઇન્ક્લુઝન એન્ડ એક્સક્લુઝન ક્રાઇટેરિયામાં જઈ શકે. એઝ ધ સર એક્સપ્લેન દેટ ઇટ ઇઝ અ ઓબ્સ્ટ્રક્ટિવ ડિસઓર્ડર કે રિસ્ટ્રિક્ટિવ ડિસઓર્ડર્સના પેશન્ટ PRમાં એનરોલ થઈ શકે, કે COPD છે, ઇમ્ફાઇસીમા છે, બ્રોન્કેક્ટેસિસ છે, સિસ્ટિક ફાઇબ્રોસિસ છે. અને રિસ્ટ્રિક્ટિવ ડિસીઝ દેર ઇઝ અ ILD, પેરેન્કાઇમલ લંગ ડિસીઝ એઝ સર સેઝ, એન્ડ સાર્કોઇડોસિસ. Some cases chest wall surgeries are also important for the PR. And inclusion exclusion criteria, there is a psychological upset patient, unstable angina are the exclusion criteria for the pulmonary rehabilitation. As sir explained, what are the main components of the PR is the main first assessment of the patient, education to the patient, as well as exercise training, behavioral support and psychological support, and main the nutritional support to the patient. Now our role for the PR is the pulmonary care. So as a physiotherapist, what are the pulmonary care we can take for the patient? First is the postural drainage. If the heavy secretions is there, as you know that the pulmonary patients have heavy secretions, so postural drainage is a must useful thing. In the postural drainage, there are very vital positions and sitting positions like lying positions. So in that position, you can use the various clapping as well as the percussion and vibration. Various breathing techniques are there. For example, the diaphragmatic breathing, purse sleep breathing, thoracic expansion exercise. We can use the breath holding techniques for the breathing techniques. I can show the video that patient is performing the spirometer and he is a patient of COPD. This is a red rubber balloon therapy. For the expiratory techniques, we can use a red rubber balloon therapy. For the expiratory capacity, if the patient has reduced the expiratory capacity, we can use the red rubber balloon to improve the expiratory capacity of the patient. This is a bubble PEP, positive expiratory pressure. Mainly, we can use this therapy in the children for the clearing the secretion from periphery to centrally. We can also use in ILD patients for the secretion removing technique, bubble PEP. Now the cough facilitation techniques. The patient is performing the a cappella. So it is a oscillating PEP device which can use the secretions from periphery to centrally. After that, coming to the centrally, we can perform the coughing and huffing techniques to remove the secretions. It is a patient of ILD and you can see that patient is performing a cappella with the O2 support. These all are the dyspnea relieving position. As the sir says that in COPD, asthma, parenchymal lung disease, during the exercise we can monitor the dyspnea, breathlessness with the O2 support, and there is no therapy that dyspnea relieving position is the most important position that the patient can helpful to relieve the dyspnea during the therapy. In pulmonary rehabilitation, we can use the two main things apart from breathing techniques. There is the endurance training and the strength training. In endurance training, we can use the stepper, bicycle, and the treadmill training. And in the strength training, we can use this patient is performing the step. This is a static bicycle. Patient is performing the static bicycle with the help of arm movement and is a patient of ILD. This is a strength training. For the upper limb and the lower limb strengthening exercise, we can use the TheraTube, TheraBand, dumbbells for the strength training because as sir says, there is a musculoskeletal deconditioning in the pulmonary cases. Usually we are performing the PR for 24 sessions and thrice a week or twice a week, and duration of the treatment is 45 minutes to 1 hour. This is a inspiratory muscle trainer. After achieving some goals, after 2 weeks or 3 weeks, we can start the inspiratory muscle trainer to strengthen the inspiratory muscles like diaphragm. And the dosage of the strength training is 50 to 60% of 1 RM. As you know that 50 to 60% of 1 RM, basically we can start from that for strength training. Yes, and most important thing in the pulmonary rehabilitation that continuously we have to monitor the oxygen saturation, whether it is a patient supported on O2 or not. We have to measure the O2 support, that patient is not desaturating while the therapy. Thank you. Any questions? Thank you.
Thank you, Jainam sir. We're almost there, guys. Please bear with me for 5 more minutes. So before we go, we would like to extend our heartfelt gratitude to our esteemed speakers for sharing their wealth of knowledge and expertise. And to show our gratitude, we are going to present mementos to our speakers. First, I would like to request Jagrut sir to present a memento to Deepak sir. Deepak sir, please. Jagrut sir. Ajinomoto. Next, I'd like to request Ketan sir to present a memento to Amit sir, please. Now I'd like to request Jigar sir to present a memento to Gopal sir, please.
I wish we should have a more and more pulmonary rehab units because the lung conditions are very bad, and we faced in COVID also. We had so many patients. They are improving with a good physiotherapist because that disease takes some time to recover. So in that, the patient moral should be fine, and also the exercise tolerance and everything should be.
Next, I would like to request Alpa ma'am to present a memento to Piyush sir. Piyush sir, please. Thank you so much, everyone. Just 2 more minutes. Thank you बोल दो last. आप सभी को पहले for being so patient, being so participative, and for coming here on Sunday. And I would also like to thank our speakers for sharing their knowledge. And lastly, I would also want to express my deepest appreciation to the management of Avron team, Jigar sir, Alpa ma'am, and to the entire team of Avron Multispeciality Hospitals. and those who have worked tirelessly to make this event possible. Lastly, guys, I would like to request you to share your feedback on the Facebook or Google. And we have prepared a framed certificate for you all, which we would like to request you to collect from the Saturday. So this is the kind of certificate that we have prepared for you. It was quite difficult for us to carry all the certificates over here. So we would please like to request to visit our hospital on next Saturday and collect your certificate. Next, before we disperse, I would like to request you all to stand up for the national anthem, and then we'll proceed for the lunch. Thank you.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you so much, everyone. Thank you. Have a wonderful day. Jai Hind, Jai Bharat.